manage everything. But we should know what are the don'ts and when we should refer the patient. So that patient will be also safe and we will be also safe. So what is ECG? ECG, the name itself says electrocardiogram. That is the electrical impulses. The electrical impulses that is generated inside the cardiac, inside the heart, that will be depicted as a gram or will be in a graphical form, in a wave form that will be represented in a graph paper. That is called electrocardiogram. Next slide. So the electrical impulses that is traveling inside the heart are measured and recorded in a graphical pattern that is called as electrocardiogram. So we all know the electrical impulses from where it is generating. It is generating from the SA node, then it will be traveling to the AV node, then it will be traveling to the bundle of it, and then it will be traveling to the Purkinje fibers. This is how this electrical impulses travel. And what happens when this electrical impulses travels? There will be atrial depolarization, ventricular depolarization, and ventricular repolarization. What it is? When these impulses will be traveling, the atrium will contract, ventricle will contract, and ventricle will relax. So these three stages will be taking place inside our heart. So these three stages will be coming out in a graph as a waveform. So next slide, how it comes? It comes, this is the pattern. So this is the SA node, somewhere in the RA. This is the AV node, somewhere near the interventricular septum. This is the bundle of it, and these are the Purkinje fibers. So the impulse, like this means a current. It will be generated from the SA node, will be passing through. And when it comes to the Purkinje fibers, the electric current will be passing through all the muscular portion of the heart. So heart will contract. This is what is happening. So how it comes as a graph? Next slide. It comes like this. It comes as a P wave, a Q wave, an R wave, an S wave, and a T wave. Please don't ask me why it is PQRST. It is like that only. Why they are named ABCD? I don't know. It is PQRST. So what is P wave? Atrial contraction. So if there is any problem in the P wave, some problem in the atrium. What is this QRS? It is a ventricular contraction. So if there is any problem in the QRS, it is ventricular problem. What is this T wave? This T wave is ventricular relaxation. So three things I told. These three things will be there in the normal ECG. This is a normal waveform, normal ECG pattern. A P wave followed by a QRS and a T wave. Every ECG should have this. P wave should be before QRS, and after P wave we will be having this QR. The P wave will have a QRS complex. Okay. So we all know the circulation. So from the upper parts of the body, the blood will be coming from the superior vena cava, and from the inferior parts will be coming from the inferior vena cava. It will be going to RA. Then after RA, it will be going to the tricuspid valve, RV. Then it will be going to through the pulmonary artery, through pulmonary valve to the lungs. Then it will be making into oxygenated blood. Then from there it will be going to through the pulmonary artery, pulmonary vein. It will be coming to LA. Then through the mitral wall, it will be going to LV. Then there from LV it will be going to the aorta. This is the circulation of the heart. This is the systemic circulation, everyone knows. So all these things will be there in this waveform. Okay. The next. So how will you get an ECG? You will get an ECG by 10 electrodes you have to fix on your body. The body surface will catch these electric impulses. So 10 electrodes, where you will keep 6 electrodes you have to keep in the chest, and 4 electrodes you have to keep in the forelimbs, 2 upper limb and 2 lower limb. This is the thing. So 6 limb leads and 6 chest leads. Limb leads. Now on next slide, if you show me. So you please show me the next slide. So next slide. So this is a normal ECG. This one I have named now 1, 2, 3, AVR, AVL, AVF, V1 to V6. This is the normal ECG, and this is called as leads. So this is all this is, they have to accept the why it is called lead. It is called lead. This is named like this. This is in its pattern. So 1, 2, 3, AVR, AVL, AVF, V1 to V6. This V1 to V6, they are called chest leads, and 1 to AVF, they are called as limb leads. So whatever information you are getting from the limbs, you will be getting in this 6 leads, and whatever information you are getting from the chest, that will be you will be getting in this V1 to V6. Okay. Now, previous. Okay. I told you no. Okay. Limb leads, chest leads, electrodes 4 in the arms and 6 in the chest. Next one. So where will you keep in the chest? So this is the right side of the sternum. So fourth intercostal space, you have to fix the V1. Next, in the left side of the sternum, in the fourth intercostal space, you have to keep the V2. So V4, between V2 and V4, you have to keep the V3 electrode. V4 is nothing but the mid-clavicular line in fourth intercostal space. And V5 and V6, this is the axillary line, lateral and medial axillary line. You have to place the electrodes. These are all be fixed by the ECG technician. Yeah, I think everyone would have seen how they take an ECG. Hope so. Everyone has seen, no, how they take an ECG. So this is like they keep the electrodes in your body. They fix the electrodes in the upper arm, and when you switch on the machine, you get the graph. Next slide. As this pattern. This you have to register in your mind. Some tips and tricks what I followed, or there are some tips and tricks for this normal ECG. Always there should be a P wave before QRS. There should be a QRS after a P wave. Okay. Then this is a P wave. This is called R. Correct? No. So P R interval should be more than 3 small squares. Can you see? Okay. Next, this QRS complex should be within 3 small squares. Okay. There is that small squares. Can you see? So it should be a normal ECG. PR interval should be 3 to 5 small squares, and a QRS complex should be within 3 small squares. In lead area, all leads should be negative. See, negative reflection. This is the baseline. Whatever is upward, it is positive. Whatever is downward is negative. So all things should be negative. And most of the things, it's a minor Q wave is here. There should be a minute Q wave in lead, or sometimes there should not be a Q wave. So P waves, PR interval should be like 3 to 5 small squares. This should be within only 3 small squares. All leads should be negative in area. Next, P wave, this R wave is slightly progressing. Small height, little more height, little more height. Can you see? So it slightly should increase from V1 to V3. And now you see the S wave. S wave is slightly increasing from V1 to V3. Okay? If you feel like this, then it is a normal ECG. So these are some simple tricks. If you follow this, it's a normal ECG. Okay? I will go to the next. So rules. I told you, no, PR interval should be 3 to 4 to 5 small squares. QRS should not be less than 3 small squares. All waves are negative in area. R waves increase from V1 to V4, and S waves increase from V1 to V3. And this Q wave is also there. Q wave should be very minimal or not there in lead 2, or mostly it should not be there. Q wave indicates it's a myocardial ischemia. That means the heart cells are dying. So that should not be seen in a deep Q wave, should not be seen in a normal ECG. Okay. Next one. What all you can see in an ECG, what all you'll be getting in an ECG is heart rate, rhythm, PR interval, QRS interval, P waves, abnormal Q waves, ST segments like arrhythmias, MI, pericarditis, electrolyte imbalance, and U waves. These all we can infer from an ECG, but in our OP level, main thing, 2 things you have to see, rate and rhythm. These 2 things you see and you segregate the patient. So I'm going to concentrate only on these 2 things. Okay. Next slide. Heart rate. How will you know the heart rate? Everyone knows in a normal ECG, this right hand side corner, they will be writing the heart rate so that you can easily see. But easy way to calculate this, you just take 2 R intervals and divide it by 300 divided by 5 small big squares. 1 square, 2 square, 3 square, and 4 square. So 300, you divide it by RR interval, how much small squares are there? Divide number of big squares by 300 with the 2 RR interval, you will get the answer. So heart rate from 60 to 100, we consider it as a normal heart rate. Less than 60, we call it as a bradycardia. More than 100, we call it as a tachycardia. Okay. So next slide. I have 2 pictures for you. What is this ECG? Can you guess? So RR interval, only 2 small squares is there. So 300 by 2 will be only 150. So heart rate is more than 100. This ECG shows it's a sinus tachycardia. Okay. Next slide. Now it's here name only about it's a sinus bradycardia. So it is 1, 2, 3, 4, 5. 5 small squares. So you have the 300 divided by 5. I think it's right. What is the answer? So it's normal ECG. It's a sign. No. It's a sinus bradycardia. It is less than it's like 1, 2, 3, 4, 5 only. Okay. So it will be a sinus bradycardia. Less than 60 comes for sinus bradycardia. Okay. Next one. Now this is very important. I think you can take a picture of this. Now I showed you all the leads. 1, 2, 3, avial, AVF, V1 to V6, chest leads and limb leads. So if you have ST segment elevation more than 1 mm, use 1 mm elevation. I'll show you the pictures. If you see that, I think it will be easy for you. If you get the 1 and lateral lead, avial lead, if there is ST elevation, it is called a lateral wall myocardial infarction. If you get ST segment elevation in lead, if you see ST elevation in lead 2, 3, AVF, it is called an inferior wall MI. And if you get ST segment elevation in V1, V2, V3, 4, it is anterior septal MI. And V5 and V6 also 1 avial, V5, V6, it is a lateral wall MI. Okay? They have see all green shades, all yellow shades, or blue shades, and these. Okay? You just take a picture of this. If you have this one, then you can. It's very easy to read an ECG. Okay? I'll go for the next slide. ST segment elevation. Previous slide. You want the previous. ST segment elevation in lead 2, lead 3 AVF. In limb leads or there no limb leads in ECG. I show you the picture, then only you will be recognizing. Then it is called an inferior wall myocardial infarction. Next, if you have ST segment elevation in V3 and V4, it is anterior wall myocardial infarction. If you get ST elevation in 1 avial, V5, V6, it is a lateral wall myocardial infarction. In India, anterior wall MI and inferior wall MI is very, very common. So most of the 90% cases what I have seen is only inferior wall MI and anterior wall MI. I have never seen any posterior wall MI cases, and I think only 2 or 3 cases I have seen lateral wall MI cases. I think Alagar posterior wall MI. It's very, very rare. They say in Indians don't get posterior wall MI at all. Okay, this way if you take a snap, it is okay. Now next slide, I'll tell you. This one just to explain you that myocardial infarction, I put this picture. Heart will be like this. Now the coronary arteries will be flowing on the surface of the heart. So major will be from left side and right side. Left side will be called as left anterior descending coronary artery, and right side is called as a right coronary artery. And left anterior descending it will be dividing into left circumflex artery, and then it will be further dividing into diagonal artery. So what I told, when you get ST elevation in the anterior leads, V1, V2, V3, V4, you get a myocardial infarction of anterior wall. So what happens? This block, it gets blocked. This coronary artery gets blocked. So no flow to the anterior surface of the heart. So what happens? The patient presents with chest pain, giddiness, sweating, and low cardiac output state with peripheral sound wall will be cool. No limb pulses will be there. That time, you will have a ECG of ST elevation in the anterior leads. Next, this right coronary artery, this is supplying the right side of the heart. So when you get blocked in this artery, you will be having ST elevation in lead 2, 3 and AVF. So right coronary artery is blocked, right side of the heart does not get the oxygenated blood, so you get a myocardial infarction. What is that myocardial infarction? The coronary artery gets affected, blocked by a thrombus or a blood clot. So in the rest of the heart is not getting the oxygenated blood. So what happens? Heart cells start dying, all cells gets ischemic. That is called as myocardial infarction. That is a very, very medical emergency. You have to immediately save the patient. So you have to immediately refer the patient. Okay. Now the next slide. This one you just have the picture. I think this one is clear. The next slide. Now I think you will be better than me now. You have ST elevations in V2, V3, V4, 3 slides. Can you notice this ST segment? So it is like QRS is like this. Now here STs are like this. Elevation more than one small big square. This is called as ST elevation. Okay, ST elevation in lead V2, V3, V4, already I told it is an example of anterior wall MI. Okay, this picture is clear? Okay, next. Now tell me, ST elevation is in 2 2, 3 and atrium. Limb leads. This is the ECG of inferior wall myocardial infarction. So when you see this ECG itself, you can say right coronary artery is blocked. You have to emergency shift the patient for cath lab and you have to open the artery by a stent. So this is the right coronary artery picture. Next one. Lateral wall MI. Lateral wall MI I already told you. ST elevations. 1 AVL. These two are significant. V5, V6 also you can leave. 1 AVL, if you see itself, it is a lateral wall myocardial infarction. So in anterior wall, left anterior descending coronary artery will be blocked. Inferior wall, right coronary artery will be blocked. Lateral wall MI, I showed you a branch of LAD, left circumflex artery will be getting blocked. So you will not get heart blood supply to the lateral part of the heart. So it is ischemic, you will getting lateral wall MI. In the next one. Next one is the posterior wall MI. I have never seen such a case. Only one key is V2 and V3, there will be an ST depression like this, a flat line. Can you notice this? Everywhere there was an ST elevation. Here you will be having a ST depression. Now posterior, why you know, this chest leads and limb leads, it is like taking a picture of a heart like from a 3D. From you are taking the heart picture in all angles. But you will not be able to take the picture of the heart from the back. So posterior wall, when you take the ECG, you will not get ST elevation at all. So without ST elevation, you cannot send, you can think that the patient is not having MI, you should not send the patient home. So this is the key. It is like a mirror image. You have to keep upside down and see. So V2 and V3, there is a ST depression with a horizontal waveform. So this is the posterior MI. Very, very low incidence of posterior MI. Maybe 0.1% only patients has this posterior MI and ETNs don't get this. Like that, this is the report they are saying. Next, whenever patient is going to get an MI or after an MI you are reverting, patient may go into atrial fibrillation. So what is this one? There is a RR interval is not regular at all. Here it is 1.5 slide, 1.5 big square. Here it is 3 big square. Here it is 4 big square. Can you see? So whenever you want to analyze an ECG, go for lead 2 is called a long strip ECG, where you can know about the ischemias. So easily you can diagnose the patient. So what is here? P wave is also not, somewhere P wave is there, here P wave is there. RR interval is not proper, not regular. This is called as atrial fibrillation. What it means? Atrial is fibrillating. Fibrillating is like this. It's moving like this. It is not moving in a regular pattern. So AF, so when you will have this, when there is low potassium, you will be having this level. And sometimes after an MI or before going to have an MI, you will be having this atrial fibrillation rhythm. Okay? So when the patient is having reduced cardiac output, what is the possibility? Stroke. Why? When there is a normal sinus rhythm, blood will be normally flowing inside all over the body. So when it is not rhythmatic, immediately there is a pattern of forming a thrombus or a clot. So it may traverse. Whenever it travels, it will be just going as it goes. So where your artery is very small, it will go and block it. So what will happen? When it goes to the lower limb, you have a stroke, lower limb ischemia, or you have a left hemiplegia. When it goes to upper limb, you have a left upper hemiplegia paralysis. Or when you go to the brain, you'll be having a stroke. So that is what this rhythm is very, very important. Atrial fibrillation, you see the RR interval is not proper. You have to send the patient to the cardiologist. Next slide. There is another one. It is called atrial flutter. Here also RR interval is not regular. But what is the, if you see the ECG itself, you can find out saw-toothed pattern. Correct, no? This is the saw-toothed pattern. So this is called as atrial flutter. So before atrial fibrillation, this may occur, or after atrial fibrillation also atrial flutter may occur. Okay? These two things for atrial abnormality. So somewhere some problem with the SA node. SA node is sending the electrical impulses. That time it is only atrial contraction is happening. That time atrial contraction is not happening properly. Some delayed, some pulse is not proper, or somewhere there is a blockage, or something is happening in the ECG. You have to refer. Next is the VT rhythm, very, very dangerous rhythm. It is called as ventricular tachycardia. Why I am saying tachycardia? Many QRS complex, no P wave at all, only QRS complex. The thing is wide QRS. So there is no P wave, no atrial contraction at all. Only ventricle is contracting very, very fast. So what is going to happen? It is going to stop. The next or few minutes, patient is going to die. The next few minutes, you will get a flat line after VT rhythm. So this is called as VT rhythm. Okay, ventricular tachycardia. Ventricle is only contracting. So wide QRS, no P wave, rate is more. Can you see? Rate is more. In this patient, presenting will be like 150 to 200 will be heart rate. Next rhythm. After VT rhythm, you will be going for this VF rhythm. No P wave, no QRS complex, no wide. So nothing, no electrical activity or electrical activity before a flat line or an asystole rhythm, you will be getting this ventricular failure. So ventricular beating very fast, it now is going to stop. So that is called ventricular rhythm. VF rhythm, ventricular failure. Ventricular is failing to beat. Next, these are the MI. These are the MI ECGs what I showed. Anterior, lateral, inferior, posterior MI. After that, you will be getting an AF, atrial flutter, VT, and VF. Now we'll go for these are the stable patients. Will be walking to their OP. First degree heart block. This is physiological only. If not physiological, it is very common. You can neglect it also. What is the thing? The P wave and QRS complex. There should be more than one big square. See, one big square difference is there, no? That means it is called as first degree heart block. Where you will get this, patients, all cardiac patients will be having the beta blockers. Like they will be taking the beta log, metoprolol, etc. No? That drug or a side effect, they will be prolonging the P wave and the QRS complex. So what is happening? So there is a big gap. So it takes so much time for the SA node, the impulse is passing very slowly to the AV node. Then after that, the ventricle will contract. So it will take so much time. So only delay. So this is called as first degree heart block. You can neglect it. Some patients you can reduce the dose of the metoprolol. You can reduce the dose of the drug, then it will revert back to normal sinus. It is not that dangerous. You can leave it, no problem. Next slide. Next slide is second degree heart block. Heart blocks are three types: first degree, second degree, and third degree. What is happening in second degree? Second degree, there is no QRS complex here. One time atrium is contracting, that time ventricle is not contracting, no QRS complex. So there will be one drop. There will be one drop in QRS complex at times. Okay? So P wave will be there, but there is no QRS complex. No ventricular contraction. That means it is a second degree heart block you have to address. This is also there in case of drug toxicity. But things what you have to see is sometimes some patient may need a pacemaker. So there is no impulse generating from the SA node is not properly giving the electrical impulse. So you have to make an alternative. You have to go for a pacemaker. Next one. Next one is third degree heart block. See, ECG is not even fine. One P wave is there, no QRS. Here also no QRS. Here also no QRS. Here there is no P wave. Here there is a P wave. Here there is no P wave. That means atrial will be contracting independently. Ventricle will be contracting independently. No coordination between them. So what is happening? It is a third degree heart block. The rate now will be only 40 or 35. Compulsorily, patient needs a pacemaker that will be implanting and below the clavicle. You have to, there will be a battery will be there. There will be a wire will be there. The wire will be there, keeping inside near the SVC. That wire will go through the RA. So for the instead of SA, the pacemaker will work. For this patient, they need a pacemaker. This is called junctional rhythm. This is seen very rare. You will not see a P wave. This is a normal rhythm only. Patients who have got operated from congenital heart disease, like ASD surgical closures, ventricular surgical closures. So those patients, they may post-operatively, they will be having a junctional rhythm. So there will be no P wave at all. Mostly you will be having low potassium. So when you correct the potassium, that time it will revert to normal sinus rhythm. This will not be a dangerous one. And another one is also when they operate, they may touch sometimes the SA node. When they close the ASD, the surgeon is by mistake by some reach the SA node. So what happens? SA node will become inflamed. So it is not able to generate the impulse. So at that time you have to put some anti-inflammatory drugs. So for 3 to 4 days it will revert back to normal sinus rhythm. This is not a worrisome rhythm. Okay, next one. This is the thing in case of hyperkalemia. Hyperkalemia, it is also a dangerous one, very high potassium. You will be seeing in case of CKD patients. So potassium will not be eliminating out. So high potassium, so you will be having a tall T waves and a wide QRS. Two key things you have to see, wide QRS and tall T waves, it represents the high potassium. High potassium 3.5 to 4.5 you can accept. More than 4.5 you have to completely reduce the potassium. Hyperkalemia will lead to asystole and patient may go for cardiac arrest. Okay, next one. Hypokalemia, I have not showed you the U wave at all. You in normal ECG, very rarely you will be getting the U wave. So P wave, Q wave, R wave, S wave, T wave. This is the T wave, it is inverted T wave and elevated U wave. This will be for you will be seeing in hypokalemia in case of low potassium. It is very rare. Even I have not seen this, I got just a pic of this. Next one, the bundle branch block. So two bundle branch block is there, left and right. So you just remember this keyword, what I am telling you, William Marrow. This is how I remember. William Marrow, two leads you have to see, V1 and V6. So V1, the ST segment pattern will be like W, and in V6, the ST segment pattern will be M. So this is the opposite in case of right bundle branch block. V1 will be M type and V6 will be W type. Just you see the ECG itself, you see these two, decide it is a left bundle branch block or a right bundle branch block. So where you will be getting this in case of coronary artery disease. What I told in MI, So after that post-operative patient, they'll be having this coronary artery disease. So they'll be having this pattern. Then the hypertension patient will be having this pattern. Valvular disease. In case of mitral valve diseases, in aortic valve diseases, you'll be having this pattern. Usually in case of mitral valve, you'll be having this pattern. So W and M. This is very just key things I've given you. Next slide. Next slide is right bundle branch block. So I told you V1 is M and V6 is W. Okay. So this is like William Marrow. You remember this V1, V6, W, M is in LVB and M, W is in RBB. RBB you can see most in case of post-operative ASDs, atrial septal defect children. They'll be always presenting with the post-operative ECG also. They'll be having an RBB and pre-op also they'll be having an RBB. So children, if you go in for a school health children's scheme, you are doing an ECG without even monitoring the step. The ECG itself, you can see that patient is having RBB, they'll be having an ASD. Okay, next. This is left ventricular hypertrophy ECG. So there, see what is the thing? You will be seeing this type pattern in case of hypertension patient and in case of aortic stenosis patient. So what is the thing? Amplitude. Amplitude is high. See, it is like very, very fast amplitude. All leads they'll be having tall T waves. So mostly in case of V5, V6, V2, everywhere it is very, very strange. Can you notice this? This is called left ventricular hypertrophy. That means the left ventricle muscles are very hard and dense because of hypertension and because they'll be having diseased and they're not able, they're putting more strength to push the blood into the system. So that is why it's called left ventricular hypertrophy. Next slide. I've already showed this picture, hyper and hypokalemia. I told no peaking of T waves, wide QRS will be there, no diminution in P wave. Then this will be leading for cardiac arrest and asystole, and in hypokalemia, we'll be having the prominent U wave. I've showed you. Next one. Now it's time for you. Just tell me. What is this ECG? It's time for you. I'll just give you a key. It's an MI ECG. No. MI ECG. I think Sheikh is trying. Yes, very good. SC elevation in V4, V5, V3 also mild. So it's an antral myocardial infarction. Good. Okay. Start. Next one. Now tell me this. I give you a key. See the lead 2. Next one, no. Sir? No, it's not sinus. It's not sinus at all. Just check. Every P is having a QRS. Just check. Or whether it's in the equal pattern. No. RR intervals are varied. No. Atrial fibrillation. Correct? No. See? RR interval small, large. Check. And last thing. One question. Not for you. Big pressures. What is this?
Left button.
Huh? Okay, it's a VT rhythm. It's a dangerous rhythm. Okay. Thank you. Syndrome. These are the common issues what I see in my OP level and ICU level. I not have taken a picture. Thank you. So I thank Ramesh sir for giving me this opportunity. Thank you, sir. Thank you.
Hello. Doctor. ஸ்டேட்களுடைய செக்ரட்டரியோ அண்ட் பிரசிடென்ட் அண்ட் செக்ரட்டரி வந்திருக்காங்க. டாக்டர் இளஞ்செழியன், டாக்டர் அருண்குமார் வந்திருக்காங்க. அவங்களுடைய வேண்டுதலை ஏற்று வெல்கம் மதுரை ஜோன். டாக்டர் மகாலட்சுமி அவங்களுக்கு வெரி தேங்க்ஸ். வெரி இம்ப்ரெசிவ், வெரி இன்ஃபர்மேட்டிவ், வெரி இன்ட்ரெஸ்ட். இவ்வளவு பெரிய நாலேஜ் உள்ளவங்களை வச்சுட்டு இது வரைக்கும் இருக்குமே நிறைய சொல்லியிருக்கீங்க. என்னால கேட்ச் பண்ண முடியல. எங்களுக்கு இன்னும் ஒரு 3 கிளாஸ் கொடுங்க. அதாவது நீங்க ரொம்ப ஸ்பீடா சொன்னீங்க. உட்கார்ந்த டீச்சர் மாதிரி எங்களுக்கு டிராயிங் பண்ணி சொல்லி கொடுத்தீங்கன்னா நான் எங்களுக்கு லைஃப்ல ரொம்ப யூஸ் ஆகும். நிறைய மோர் பேஷன்ஸ்க்கு ரொம்ப ஹெல்ப்ஃபுல்லா இருக்கும். தேங்க்யூ டாக்டர். தேங்க்யூ. அதுக்கு அடுத்தபடியாக டாக்டர் விஷாக் பி தன்வந்திரி அவங்க ரோல் ஆஃப் பஞ்சகர்மா இன் தைராய்டு டிசார்டர்ஸ் எடுக்க போறாங்க. நம்ம ஆயுர்வேத சம்பந்தமா வெரி மோர் இன்ஃபர்மேட்டிவ், ரொம்ப இன்ட்ரெஸ்டா இருக்கும். வெல்கம் டாக்டர். தேங்க்யூ.
Now we move on to the CME session 2. The future of Ayurveda lies in the hands of young physicians who combine classical wisdom with scientific excellence and innovation. It is my privilege to introduce our second speaker for today's CME. Dr.VISHAK DHANVANTHRI, MD Panchakarma, is a distinguished young Ayurvedic physician and Panchakarma specialist. He completed his EMS from SDM Ayurveda College, Hassan. Securing second rank in the university and later completed his MD Panchakarma with first rank in MD Panchakarma in STF and 7th rank in the Rajiv Gandhi University of Health Science, Karnataka. He currently serves as the director and a consultant physician and Panchakarma specialist at Yes Dhanvanthri Premils Dhanvanthri Nilayam Ayurveda Vaidyashala Private Limited, Madurai. Dr. Vishak sir has published 4 articles in International Medical Journal and presented 3 papers at international seminars and 2 papers at national seminars, reflecting his commitment towards Ayurveda and clinical research. Sir's topic is the role of Panchakarma in thyroid disorder. Now I request Dr. Ramesh sir.
Like 16:9 ratio. 16:9. Correct. That's all. 16:9. Is okay, Vishak? இல்ல உனக்கு போட்டி போண்டாரு தாதா சார் பாட்டு டாபிக் மாதிரி
Good morning, everyone. Myself, Dr.VISHAK, DHANVANTHRI, currently working as a consultant physician at Dr.S.MAHALAKSHMI BAMS. First of all, I would like to thank All India Ayurvedic Congress Madurai for organizing this event. President Dr. Nafi sir and Secretary Dr. Sanjeevi sir for giving me this opportunity in the second CME itself. I would like to thank our state president, Dr. Ilanjalian sir, for being in this CME program today. And Dr. Arun sir, secretary, for being in this event. Thank you so much, sir. Next, I would like to thank our honorable chief guest, Dr. Hariharan sir, who is the guru of Dr. L. Mahadevan sir and my father, for being in this CME. Although I have done many of my presentations in other states, this is my first time I'm doing in Tamil Nadu, and that also in my hometown. So thank you so much for this opportunity. So let me start my presentation now. So the topic of today is on role of Panchakarma in thyroid disorders. So as we all know about thyroid disorders, it is one among the most commonly encountered endocrine and metabolic disorders. So statistically speaking, women are more affected with these thyroid disorders. So in my presentation, let's see about some of the what I have in my learning objectives. That is, first is the introduction, anatomy and physiology, about Galaganda and Gandamala, Panchakarma and hypothyroidism, case discussion and conclusion. So this is going to be a pattern. So similar to how our Charakacharya and all our acharyas have written the book. Without reading Sutrasthana, if you skip and go to Chikitsasthana, it is of no point. So only when you learn Sutrasthana and go to Nidana, Vimana, Sharira, followed by Indriyasthana, then you go to Chikitsasthana and end with Kalpasthana and Siddhisthana, you will get the entire gist of what we are talking. So although ஒரு படம் பாக்குற மாதிரி தான் நம்ம படத்துல வந்து இன்டர்வல்க்கு அப்புறம் வந்து ஆரம்பிச்சா வந்து பஞ்சகர்மா தான். ஸோ அந்த மாதிரி இன்டர்வல்க்கு அப்புறம் தான் வந்து மெயின் ஷோ வர மாதிரி பஞ்சகர்மான்றது it will come in the middle part. So but initially we have to understand what is the anatomical part. I will try to be as much as brief about it because we are not going to emphasize on that, and since we know more about it. So starting, so what is thyroid gland? So thyroid gland is a butterfly shaped endocrine gland which is located in the anterior part of the trachea. It weighs approximately 50 to 20 grams in adults and consists of two lateral lobes which are connected by the isthmus. So the gland is composed of numerous follicles which represents a functional unit. So what does this thyroid gland mainly do to our bodies? BMR, that is body metabolism rate. Okay. So basal metabolism rate, and it is easy to remember with a small mnemonic, which I would like to say metabolic. So what are the functions of this thyroid gland? It improves the metabolism, energy production, thermogenesis, alertness and CNS development, bone growth, oxygen consumption, libido and fertility is maintained, intestinal motility and cardiac output and heart rate. So it is surprising like how God made our body that such a 15 to 20 gram of an organ functions and controls these many functions of our body. So how does this work? So first is we have hypothalamus. Hypothalamus secretes TRH. Okay, so TRH is thyrotropin releasing hormone which acts on the pituitary gland. Pituitary gland secretes TSH, thyroid stimulating hormone which acts on the thyroid gland. So to release T3 and T4. T3 is triiodothyronine which is 10% and T4 is thyroxine which is 90% which is released. So these are some of the normal values. So this is just to inform you before itself what are the normal values of TSH, T3, T4, FT3 and FT4. So coming to the clinical classification. So what is the clinical classification? So looking into the classification, I have classified this based into three forms. One is based on the etiology, that is the Nidana. So based on the causes, we are primary disorders and secondary disorders. So this I will come to in detail. Structural classification, we have diffuse goiter, nodular goiter and as well as CAs. Functional classification, we have hypothyroidism and hyperthyroidism. So what are the symptoms usually we see in a patient of hypothyroidism? So in hypothyroidism, we come across the symptoms like depression, fatigue, dry skin, constipation, irregular heavy periods, joint muscle aches, cold intolerance and weight gain. So these are the most common symptoms which we come across in hypothyroidism. Okay, so clinically we see three types of cases usually when they are diagnosed as hypothyroidism. So one is subclinical, second is primary hypothyroidism, and third is secondary hypothyroidism. So what is this subclinical level? So here in subclinical level, TSH level remains increased, whereas T3 and T4 levels remain normal. So here what we can interpret it is that it is the early stage of hypothyroidism. Second is primary hypothyroidism. So primary hypothyroidism is what we usually see where TSH is increased, T3 and T4 levels are decreased. So here the thyroid gland is failing to produce the enough thyroxine hormone. So third is secondary hypothyroidism. Here TSH is also decreased. So when TSH is decreased, we usually think it could be hyperthyroidism. But patient symptoms ellame vandu hypothyroidism mari weight gain ellame irukum. But why? The reason is TSH is also reduced, T3 is also reduced, T4 is also reduced. Why means, as I said, how does the thyroid gland secrete? It is from the pituitary. So here the pituitary is failing to secrete enough amount of TSH itself. So it is the case of secondary hypothyroidism. So next we'll see about hyperthyroidism. Hyperthyroidism is exactly the opposite. It is where nervousness, anxiety will be there, enlarged thyroid glands, muscle weakness, disrupted menstrual cycle, heat sensitivity, increased appetite, unintentional weight loss, frequent bowel movements, shaky hands and heart palpitations. So here we come across the case interpretation where in hyperthyroidism we see TSH is reduced, T3 and T4 remains normal. So that is subclinical case of hyperthyroidism. In primary hyperthyroidism, there is reduced amount of TSH, T3 and T4 are increased, which is primary hyperthyroidism. And when there is TSH, T3 and T4, all three are increased, it indicates it is secondary hyperthyroidism, which is caused because of the pituitary gland. So what is goiter? So we have other three diseases also, thyroid diseases. One is goiter, second is Hashimoto's thyroiditis, third is Graves' disease. So are these three complication of thyroid disorder, that is hypothyroidism, or is it something different? So what is goiter? Goiter is an abnormal enlargement of the thyroid glands that causes swelling in front of the neck. It may result from iodine deficiency, autoimmune thyroid disease, thyroid nodules, or inflammation. Okay, so it is a separate disorder. Second is Hashimoto's thyroiditis. So Hashimoto's thyroiditis is an autoimmune disorder in which the body's immune system attacks the thyroid gland, leading to chronic inflammation and reduced thyroid hormone production, that is hypothyroidism. It is commonly causes fatigue, weight gain, cold intolerance, and neck swelling. So Hashimoto's thyroiditis is itself an autoimmune disorder, which leads to the condition of hypothyroidism. It is not a complication of hypothyroidism, rather it is a separate disease in which hypothyroidism is a symptom. So similarly, in hypothyroidism, which we have Graves' disease. So Graves' disease is an autoimmune disorder in which the antibodies overstimulate the thyroid gland, causing excessive thyroid hormone production, hypothyroidism. Common symptoms include weight loss, rapid heartbeat, heat intolerance, tremors, night terrors. So here, Graves' disease is an autoimmune condition where there is excess amount of thyroid gland production, thyroid hormone production, which leads to symptoms of hypothyroidism. So these three are three different diseases and not related to hypothyroidism. Rather, they are hypothyroidism and hypothyroidism are symptoms which are seen in these diseases. So in Ayurveda perspective, we have two diseases, Kalaganda and Gandamala, which you would have all come across, and our teachers would have taught us that these are the two diseases in Ayurveda which we can correlate with thyroid. But are they? So Kalaganda and Gandamala are Medava Strotha Vikaras. So here where what Acharya Madhava says is Nibaddha Swayatva Vyasya Mushka Vallabategale Mahanva Yadi Visvo Galagandam Tamadishi. So here Acharya Madhava beautifully explains that which the swelling Swayatva which looks like Mushka Vallabategale, that is which is looking like a scrotum which is present in the gala region. Mahanva Yadi Visvo, that is Mahan means which is big and Hrisva is small, which is present in Gala, which is called as Galagandam he has told. Similarly, Acharya Charaka in Shota Chikitsa 12th chapter, he has told that Galasya Pashve Galaganda Ekaha, okay, Syat Gandamala Bhavishcha Gandai. So, first Acharya has told that it is a swelling, okay, which is present in the Gala region, which looks like Mushka Vallabha. So, which could be correlated to goiter, where rather than any of the hyperthyroidism or hypothyroidism diseases. So, what is Gandamala? Syat Gandamala Bhavishcha Gandai. So where Acharya Charaka has told Bahubishcha Gandehi, where there are multiple swellings present in the neck region, is called as Gandamala. And Acharya Madhava has beautifully explained that is Katkandu Kola Amraka Pramani. How he is telling how the swelling sizes are looking like. And where it is located, Kakshamsa Manya Gala Vangshaneshu. Meda Kapabhyam Chiramanta Pakesya Gandamala Bahubishcha Gandehi. So say Bahubishcha Gandehi has been told by both Acharya Charaka as well as in Madhavida. So he has told about the location. Kaksha refers to the axilla, Manya and or Gala refers to the neck region, function as the groin. So what is this correlate in modern terms? Gandamala refers to cervical lymphadenopathy and nothing related to any of the thyroid disorders. So what are the chikitsa the Acharyas have told is Tesham Sirakaya Shirovireka, Duma Purana Sigritasya Panam, Syat Langana Bhaktra Vishuchapi, Prakarshanam Syat Kavalagarash. So these are some of the chikitsas which they have told Galaganda and Gandamala, where Acharyas have told to go for Siraveda, Kaya Vireka, Shiro Vireka, which indicates the three of the Shodhana therapies. And he has told some of the Shamana therapies which are like Dhumapana, Purana Gratapana, Langana, Prakarshana, Kavalagraha. And as they have told about Langana, Langana indicates the Dashavida Langanas. So these is what the Acharyas have told it. In our classics. But how do we interpret hyperthyroidism and hypothyroidism? They do not completely correlate at all. So how does in Ayurveda we can correlate this? So here is what I would like to come across. So what is this is? So here we have an interesting article which is done not by some of the Ayurvedic fraternity, but this is by the modern allopathic researchers, where they have correlated intestinal microbiota, which regulates the GTA, gut thyroid axis, and a new dawn in improving the Hashimoto's thyroiditis. So here I would like to correlate that we have some interesting topic which is currently going on, among the Ayurvedic as well as in the modern parlance, which is gut dysbiosis. So what is gut dysbiosis? So gut dysbiosis is when there is an alteration between the good bacteria and the bad bacteria which are present in our gut. So we have a trillion, that is more than the humans in each of our stomachs and intestine. We have more than the human population. We have amount of gut bacteria which are present. And so these microbiodata are ones which are predominantly like actually helping out in the functioning of our whole human body itself. So what is gut dysbiosis? When there is a disruption in the biosphere which is present inside our whole body, then there is the chances of production of autoimmune disorders. So why I am highlighting this? This I will come to the end. Okay. So gut dysbiosis has been proven to have been the most common cause for autoimmune conditions, which is leading to hypothyroidism and hypothyroidism. So coming to hypothyroidism. So how in Ayurveda do we like correlate hypothyroidism with Ayurvedic terms? So that is why our acharyas are always told to go for avastika chikitsas. So here I would like to say about Agni and hypothyroidism. So thyroid hormones influences the metabolic activities of our body. So in Ayurveda, metabolic activities can be understood as pachana, and one of the main function is because of Agni. So hypofunctioning of the Jatra Agni, which in turn affects the Dhatva Agni and eventually brings out the pathological sequence and ultimately the disease. So hence hypothyroidism could be correlated to Jatra Agni Mandya, which leads to Dhatva Agni Mandya, and which also can be, so the principles of treatment should be on treating the Agni, Ama, Srotas and Kapasthana and Purva Chikitsa should be done. So how do we relate Kaya Agni and Kaya Agni, as we know Jatra Agni, how do we correlate with thyroid disorder? So here Jatra Agni, as we know, is situated between the Amasya and Pakvasya. It is Tejo Mahabhuta predominant. It is Pasana of the Anna, which leads to Sara and Pitta Vibhajana. So here in modern we have two gut hormones called as ghrelin and cholecystokinin. So ghrelin is what is called as the hunger hormone. Cholecystokinin is a protein peptide hormone which helps in the digestion of fats and lipids as well as in the separation of amino acids from the proteins. So how are these two secreted? Who is the controller for these two? That is nothing but which is thyroid gland. Our thyroid C cells secrete with the help of the thyroid C cells is what secretes ghrelin and cholecystokinin, which controls the gut functions. So here we would like to establish that in modern parlance also thyroid disorders and Agni have a common relation. So how are the symptoms? So how do we correlate the symptoms of hypothyroidism in Ayurveda? So here, as once Dhatu Agni level is Mandya, so we have Rasa Rakta Mamsa Meda Asti Shukra, Asti Majja Shukra. So all the 7 Dhatus go into Uttarottara diminution. So all the Dhatu Agni started to diminish. So once the Dhatu starts affected, so when the Dosha Dusha and the Dosha Dhatu Vimurchana happens, so when it affects the Rasa Dhatu, we have reduced appetite, cold intolerance, breathing difficulty. When it starts to affect the Rakta Dhatu, we see that dry skin, acanthosis nigrosis. When it starts to affect the Mamsa Dhatu, we have generalized weakness, pain in the joints, swelling around the eyes, face, goiter. When it affects the Mera Dhatu, we have weight gain, dyspnea on exertion. In Asti Dhatu, we have hair fall. As you know, Asti Dhatu, Upadhatu of Asti is Kesha and Danta. And then we have Majja is heaviness of the body. Shukra, when it affects the Shukra, we see symptoms of oligomenorrhea, amenorrhea and impotence. So what is the treatment? So symptoms of hypothyroidism can be seen as Dhatu Pradoshta Vikaras of Rasa, Meda, Mamsa. The treatment which is approached is Langana, Agni Deepana, Amapachana and Shodhana. And as Acharyas have told, when there is Alpa Dosha Lakshanas, we have to go for Langana. Madhyama Dosha, go for Langana and Pachana. And when there is Bahudosha Avastha, go for Shodhana. So here Acharyas have told about Langana. So what is Langana? Is it only fasting? So Acharya Charaka and 16th chapter he has told, Sutra 16th chapter he has told about Dashavida Langana. Chatushprakara Samshuddhi, Vipasa Maradatapo, Pachananya Upavasascha, Vyayamastheti Langana. So what is Chatushprakara Samshuddhi? Chatushprakara Samshuddhi refers to the 4 types of Shodhana therapies which are indicated. So here I would like to say Langana not only indicates fasting, but it is the Dashavida Langana and Chatushprakara Samshuddhi, that refers to the 4 types of Shodhana, which is Vamana, Virechana, Shodhana Niruvasti, and Shodhana Nasya. So some of the medicines which are commonly prescribed for the stage of Ama, when there is Ama Avastha, we have to go for Ama Pachana and Agni Dipana, which is Vikatu Churna, Hingvastaka Churna, Shadarana Churna. In Churnas, Vatis we have Chitragadivati, Agni Tudyavati, Shadarana. In Kashayas we can go for Gandharvastani Kashaya, Pachana Panchagola Panta, Shruti Kashaya. Asavarishtas include Jiraka Reshta, Abhaya Reshta, Chitrakasava. As well as when there is Pittanu Bandhavastha, you have to go for Tikta Pachana Dravyas like Shadaha Banya or Amrutodra Kashaya, Patala Katroni Kashaya, Nimbadi Kashaya. So how do we correlate hypothyroidism and Panchakarma? So hypothyroidism, we have depression, fatigue, weight gain, anemia, skin conditions, impotence, heaviness, tiredness. All these conditions are seen. So when Acharyas have told when Shodhana is indicated, when there is Bahudosha Avastha. So what is Bahudosha Avastha? Bahudosha na Punadosha Avatechnaiva Karyam. Avipaka Arichistaulyam Pandita Gauravam Klamaha Pidaka Kota Kandunam Sambhava Arithirevach. Shleshma Vitta Samuklesha Nidranashwati Nidrata Chandra Klaibya Buditam Ashastam Sapna Darshana Bahudosha Lingani Tasmai Samshodhanam. So here Acharyas have told these are the lakshanas which we have to look forward. So when Bahudosha lakshanas are attained, we have to go for Shodhana Karma. So here we see Avasada and Klama, which correlates to depression and fatigue. Staulya and Pandu, which correlates to weight gain and anemia. So Pidaka and Kota refers to all the skin conditions which occur. Klaibya and Gaurava refers to the heaviness and tiredness. Restlessness and insomnia, which indicates Shrama, Nidranasha, Avipaka. So all these conditions, if we see, hypothyroidism shows exactly what Bahudosha lakshanas are indicated. So it is directly indicated for Shodhana Karma. So next, let's come into the practical approach. So who are the types of patients visiting Ayurveda clinic? How to plan Shodhana and etc. So we have 3 types of patients who are visiting. So one is a patient who already is a known case of hypothyroidism. They want to either reduce the dosage of the levothyroxine or thyronorm which they are taking. Second is a person who is coming with a different condition. Could be RA or could be an osteoarthritis patient, could be having a sciatica or could be having some of the gut issues. But also his associated complaint could be of thyroid. Third is newly diagnosed patient who has never taken supplements but entering our clinic. So these are the usually type of patients who are coming. So in all of them, can we go for Shodhana? So Shodhana itself, if you see, when we have multiple complaints, can we write? We can't keep writing for each complaint one of the medicines. So that is why the concept of Shodhana, where we go for Dosha Harana comes. So Dosha Harana removes the doshas which are common in all the diseases together at once. So what is the relevance of Panchakarma in treating hypothyroidism? So Panchakarma comes in 2 forms. One is preventive, second is curative. So as all our acharyas have told, the first pradhana karma of chikitsa is Nidana Parivarjana. Nidana Parivarjana is prevention. So where we go for 2 methods. One is in preventive we go for Ritu Shodhana, where Ritu Shodhana is, that is in every Ritu, acharyas have told some of the Shodhanas which are to be practiced. Vasantika Vamana in Pravrit, Vasti, Paravrit and Grishma Vasti. Then we have in Sharad, Virechana Karma which is to be done. And some of the Dinacharya and Bahyopakramas. Next is on the curative. So curative, we have choice of Shodhanas. We have Vamana, Virechana, Shodhana Niruvasti and Nasya. So how to select? That will be the major question. We know Shodhana to be done, acharyas have told. For whom but Vamana should be done, for whom Virechana should be done, for whom Bhakti should be selected, and for whom Nasya should be selected. All the 4 will work, but how and for whom it has to be selected. So before all that, first let me brief a small, take a small time to just brief on how Panchakarma works. So what is Panchakarma? Here Pancha Shodhana, as I would like to say. First, the method how to start Shodhana is on Deepana and Pachana. First starts with reduction of Agni. Starts with the Deepana of the Agni. Deepana and Pachana should be done. Before Snehana, acharyas have told to go for Rukshana Karma. Followed by Rukshana, Snehana, Swedana. Then we have the Pradhana Karma, which is Vamana, Virechana, Vasti, Nasya. Then followed by that is the Paschatkarma. Followed by that is Samsarjanakrama. Only when that is all these procedures are done together is called as the complete Shodhana. So starting with Rukshana. So what is the importance of Rukshana and hypothyroidism? So in whom Rukshana is indicated? Acharya Vagbhadan Ashtanga clearly says, Mamsala Medra Bhuri Shleshma Vishamagneha Snehochitasya Snehayetta Purvayam Rukshayattata. So the words Mamsala, Medura, Bhuri Shleshma, Vishamagneha. So all these four conditions directly correlate to the symptoms of hypothyroidism itself. So how to go for Rukshana in these? So how to go for Rukshana is, that is, we can go for two methods of Rukshana. So one is the Abhyantara Rukshana and the other is Bahya Rukshana. Bahya is the external therapies where we go for Udvartana or with Ruksha Kashaya Parishekas or like Dhanlyamla Parisheka or Takradhara. Abhyantara Rukshanas is what we had already seen, Pana, Anna and Veshja. Pana could be Panchagola Panta, Shunti Kashaya, which are given. Anna refers to the food which we are giving. It should be Lagu Bhojana and Anabhishyanti, which is to be given for the patients so that Agni Deepti will take place. Third is the Beshaja, which we go for the selection of Chitragadivati or Agni Truttivati or Sadharanavati, which are given, which does the Rukshana Karma. So once the Rukshana is attained, then only Snehana can be given. So, but how to give the Rukshana and to when to stop the Rukshana, that is, when you see the Samyak Rukshana Lakshanas, that is Vata Mutra Purchana Misraga Gatra Lagave, Tantra Hridayodgara Kantasya Shuddho, Tantra Klama Agate. So when these Lakshanas are attained, it is good. We note that we have to stop the Rukshana Karma and to go for the Snehana Karma. So one common thing which I have noticed is, some of the precautions are to be taken when we go for Rukshana therapy, which is Vata predominant persons. As in Vata predominant person, we already have Ruksha Guna which is predominant. Changla Desha such as Madurai, where we have already Rukshata which is increased. So here we cannot go for more amount of Rukshana, and henceforth we usually start with Churnapinda rather than Dhanyamadhara itself. Third is duration of Rukshana. So duration of Rukshana should be stopped when Samyak Rukshana Lakshanas are attained. So next, once that Samyak Rukshana is attained, we have to go for Shodhananga Snehapana. So selection of Snehapana, we can either go for Grita or Taila. Pasa and Majja are not commonly practiced and it is very much hard to be given. So Grita and Taila. So how to select Grita and Taila? Grita, as we know, is indicated for Grita is indicated for Vata Grita Prakriti person, and when there is Sharad Ritu, you can go for Grita. When Taila is indicated for Kapha and Veda predominant and Vada Prakriti person and Krura Kosta and in Pravat Ritu, you can go for selection of Taila. So some of the commonly used snehas which are used for Shodhananga Sneha purpose are Varunadigrita, Guglutikta Grita, Pipilyadigrita, Panchatikta Guglugrita, Dadimadigrita, and Taila is Murchita Taila, which is commonly used for Shodhananga Sneha. Shodhana Purva Swedana. So where is Swedana? What we do is during the course of Vishrama Kala, that is the period after Sneha, when the Samyak Snehana Lakshanas, Vatana Lomyam Deepta Agni, Vacha Sneha Samyatam, Madhavam Snehatam Change, Snigdhana Upajayate. That is, once the Samyak Snehana Lakshanas are attained, we have to go for the Vishrama Kala where external Bahya Snehana and Swedana done. So here we can go for Parisheka Sweda, Bashpa Sweda, Ushna Jala Snana. So followed by that is Vamana Karma. So why Vamana Karma will work here is because Vamana is mainly indicated for Urdhva Bhava. That is, thyroid is present in the Gala and Gala is present in the Kaphasthana. Hypothyroidism can be condition where there is Kapha Avarana. All the Shodhana Karma helps in Shrota Vishodhana. We have Pratiloma Gati of Vata, Kapha Chedana, increased Dhatvagni, and it removes the Mala Sanga. So, how to go for Vamana Karma? Factors to be considered. That is, patient should be first Vamya. Vamya indicates, that is, if the person has never taken vomiting in his life at all, or if the person has esophageal varices, so that person are contraindicated for Vamana. If there is an ECG abnormality, then you should not go for Vamana. Kapha Prakriti person. In a Kapha Prakriti person, it is easy to conduct Vamana Karma. In Kapha Kala, especially in Vasanta Ritu, when the person is having conditions like obesity, depression, joint pain, swelling, Agni Madhya, skin disorders, mental disorders, then we can go for Vamana Karma. So commonly used dravyas for Vamana Karma, Madana Phala and Amarga which are done. And also we have Vamanopaka dravyas which are used, Nimba, Ishtimadu Panta which are commonly used. So here I would like to highlight that in our practice, when I was in PG, some of the conditions where we required avara shuddhi, that is, you have to look for the rogi and rogabala of the patient when you are going for vamana karma. Not everyone you should go for pravara shuddhi. Acharyas have never told pravara shuddhi for every person who is undergoing vamana. Pravara shuddhi is been indicated for who is having pravara bala. When the person is having avara bala, then you have to go for avara shuddhi only. Acharya has never told that why should avara shuddhi is also a form of shuddhi. If there is complication, then it comes under vyapat, and then you have hina, that is samyak yoga, ayoga, and atiyoga. If there is a complication, then it comes under ayoga or atiyoga. It does not come under avara shuddhi. So avara shuddhi is indicated for avara bala person. So imagine a woman who is coming of more than 95 kg and admitting for hypothyroidism, and you are planning for vamana karma. Do you think pravara shuddhi will work immediately? You cannot. So initially you have to go for avara shuddhi and repeated shodhana karmas. Puna shodhana should be given to such a person. So here I would like to highlight one of the case studies which is done and published in Ayurveda journal. So it is the effect of Vasantika Vamana Karma, which is done on TSH levels. It is a case study which is done in Government Ayurveda College, Bangalore. So here they have taken 6 individual participants who have been diagnosed with the case of hypothyroidism, and they have been registered for Vasantika Vamana camp. So Vasantika Vamana camp, which is done. So in Vasanta Ritu, Vamana Karma is indicated. So generally in Vasanta Ritu, what happens? Kapha is in Utklesha already. So here we are going for, so they have taken Vamana Karma during the Vasanta Kala. So what was the result which was seen in these patients was that in all the 6 cases, TSH levels which were reduced. Okay, so 17.81 was the TSH level in case 1, which was reduced to 9.51. In case 2, TSH level, which was 8.54, was reduced to 4.99. So this is the effect of Vasantika Vamana or Vamana Karma, which is seen when you are doing it on hypothyroidism patients. So next, we will see on Virechana Karma, how it is helping in hypothyroidism. So in whom we have to go for Virechana? Person should be first Virechya. Virechya in the sense, all the indication and contraindication which is explained in Charak Siddhistha in the 2nd chapter, first that you have to see and then separate the person whether they are fit for Virechana or not. Second, if the person is Pitta Prakriti person, and then if we are having already lakshanas like burning sensation, hot flushes, obesity, and it is also Pitta Kala like Sharad Ritu, then for the purpose of Srota Shuddhi, we can go for Virechana Karma. So what are the common medicines which we give for Virechana Karma? Avipattikara Churna, Trivrit Leha, Eranda Taila, Nimbamrata Taila, Vishraka Sneha. Vishraka Sneha has been one of the like upcoming medicines which is used for Virechana Karma. It is being told in Gulma Chikitsa, in Charaka Chikitsa, 5th chapter, Gulma Adhyaya, where they have told about Vishraka Sneha. Vishraka Sneha, 8 ml of Vishraka Sneha induces more than 20 Vegas because it contains almost all the Virechana medicines in one. So just 8 ml and Anupanas Madhu, 8 ml of Sneha plus 8 ml of Madhu will induce more than 20 Vegas. It should be given. So what in Virechana also, Acharya Charaka and all, they have told that it should be easy to consume. Vamana medicine should be Vibhatsa, which is hard to consume. Whereas Virechana medicine should be Sukha. It should be easy for the person to consume. Trivrit Leha, when you give to the patient, it is more than 80 grams. Almost we are giving 80 to 100 grams of Trivrit Leha will only produce in Madhyama Koshta around 20 Vegas. So if you see, it is very hard to consume for the patient, Trivrit Leha. Even when you give Avipattikara Churna mixed with honey also, Avipatti and Avipattikara Churna, the patient starts to get somewhat, they feel very tegatar feeling. Madhu nariya irukkranaala already Avipattikara itself has sugar, and then in that if we are adding Madhu and giving or tegatar feeling varadu. So when we administer less dose of medicine, it is the best form when you are going for Virechana Karma. Virechana Karma, you can also go with plain Tripala Kashaya also, or any of the Virechanopaga Dravyas can be plainly administered. So here is an article. So this was done in my department and Panchakarma department. So it is a clinical study on effect of Virechana Karma hypothyroidism. So here we had taken 30 patients from the IPD and TSH was analyzed before the treatment and after 15 days of Samsarjanakrama. So follow-up medicine which was given was Kanchanara Guglu and was given after the Samsarjanakrama. So during Samsarjanakrama, always you should never go for any of the Shamana Aushadhis because Agni is already Mandavastha. So once the Agni has gained into normal states, only then some Shamana Aushadhis can be indicated. So here on an average, the before treatment, the serum levels of TSH was 14.20, which was seen in 30 patients average, and after treatment was 7.46. So there was a drastic difference which was seen after Virechana Karma with the Shamana Aushadhi medicines. Third is Basti in hypothyroidism. So Basti, as we know, is indicated in all Vataja, Pittaja, Kapaja, and that is why even Acharya Charaka told Basti is considered as the Ardha Chikitsa. Shakagata, Koshtagata, Gatascha, Bharmascha, Sandhyascha, Vyadhischa. So in all the doshas and all the conditions, Basti can be given. Why? Basti does Shrota Shodhana, Agni Deepana. Basti acts at the ontric nervous system level and influences the cellular level. It stimulates the HPT axis, hypothalamo pituitary thyroid axis, by the virtue of thyroid bed connection. But how to select which type of Basti? If you see in Siddhistan itself, there are more than 350 combinations of Bastis which they have told. Even Yapana Basti itself, there are more than 100 types of Yapana Basti preparations, and Sushruta in 38-39 chapter has told about more than 200 types of Basti. So which type of Basti should be selected? So Basti should be selected based on Samiksha Bhavas. That is Dosha, Aushadha, Desha, Kala, Satmi, Agni, Sattvadi, Sattva, Vyayani, Bala, and etc. So based on Dosha, Aushadha, Desha, Kala, Agni, Sattva, Vaya, and Bala, we have to go for the selection of the Bastis. So here I would like to highlight some of the common Bastis which we were used in practice over there. So commonly used Bastis, first is Tripula Kvata Gomutri, Shaudra Sara Samayuta, Ushakadi Prativapascha, Lake Basti Lekanasprita, told in Sushruta Chikitsa 38th chapter, which is Lekana Basti. So here the dosage of Madhu is 100 ml, Saindava 12 grams, Sneha which can be used as Tripala Taila, Pipalaya Taila or Brihat Saindava Taila, Kalkas which were used as Tripalaya Taila, Ushakadi Gana, as you know, Ushakadi Gana contains two types of Kasisa and Shilajitu. So usually not practiced because Rasa Aushadhis we try to avoid when it comes to Basti preparations. So Ushakadi Gana is usually not practiced when we are going for Lekana Basti. Instead, we go for Tripala Churna, or we can either choose any of the Lekana Dravyas. Even Katuga Rohini can be used for the purpose for Kalka Dravya. Kvata is Tripala Kvata which is to be taken. Amritsara is nothing but, usually if you put Gomutra, they make fun of Ayurvedic physicians. So we have come to a new term where we use Amritasara, which is nothing but Gomutra. Okay. So Gomutra nale, Ayurvedic physicians, they think it is wrong, but it is one of the best Kapahara and Lekana Chedana medicines which is administered. So here, Madhu Saindava Sneha, Kalka Kvata and Avapa we use Amritasara or Gomutra. Next is Vahitarana Basti. Pada Shukti Kashu Kudava, Guda Amlika Sindhu Janma Gomutrahi, Isha Tailoito Ayam Basti, Shula Anaha Amavatahara. Vaitaranam Shara Vasteyaha, Bukte Chapi Pradiyate. How many of you know Vaitarana Basti is the only Basti which can be indicated Bukte Chapi Pradiyate, even after food? Immediately, even after food, like just like Anumasana Basti, Vaitarana Basti is the only Basti which can be administered, told in Chakradatta. So why Vaitarana Basti is indicated? Because all the dravyas in Vaitarana Basti are Kapavata and they are mainly indicated for removing the ama. So Guda is 25 gram, Chincha is 50 gram, Saidava 12 gram, Sneha which can be taken Pipalaya Taila or Brihat Saidava Taila can be taken, and main ingredient is Gomutra which is to be taken 200 ml. Okay. So even in the sloka it is beautifully told, Palam Shukti Kashu Kudava, Amlika Guda Amlika Guda Sindhu Janma Gomutrahi. How he has given, that is the ingredients and the proportion of dravyas to be taken. Palam Shukti Kashu Kudava, the first 4 words, indicates the quantity of the dravyas. One pala, 48 grams, which is palam, which he has told us for Chincha. Okay. Shukti refers to 12 grams. Okay. 25 grams, that is Ardha Pala. Kashu refers to 12 grams, which is the Saindava. Kudava refers to 200 ml, around 188 ml, which refers to the Gomutra. Palam Shukti Kashu Kudava, Amlika Kuda Sindhu Janma Gomutra. So exact 4 quantities of dravyas and 4 quantities of the medicines which are to be given. So next is our favorite, that is Eranamoladi Sharabasti, most commonly and widely practiced Basti. Eranamolam Tribalam, Viswani Molani Chayani Pancha. Rasna Shoganda Tibala, more than 4 or 5 lines are there about the ingredients. But what I would like to highlight is the Parashuddhi, where Acharya have told Janga Uru Pada Kati Prishta, Kapavrata Marutha Nigram. Kapavrata and Marutha Nigram. Kapavrata Vata conditions is where we have to go for Eranamoladi Sharabasti. Makshika 100 ml, Saindavalam 10 gram, Brihat Saindavalam which you can go for 80 ml. The amount of Sneha or the selection of Sneha completely changes. When there is a case of sciatica, then we go for Sachra. When there is a case of Gulma, then we can go for Gulma, or we can say even in cases of renal stones, we can go for Varunadigrita. So the amount of Sneha usually changes based on the yukti of the physician. Then we have Eranamoladi Kashaya and Amritasar, that is Shara, which is nothing but Gomutra, which we have taken as Avapadraka. Then one among the another Basti, which was practiced in STM, was Puga Trim Basti. So Puga Trim was one of the churnas which we used to get over there. It was one of the medicine where it was done by one of the PG scholars. Puga means arakanut, pak. Okay. So Puga Trim Churna, one of the main ingredient was pak, arakanut, katugrohini, kadira. Okay. So all these 3 are having Vada Kapara action, and which will do the Rukshana and Lekana Karma. So this Basti which we had used was where Madhu was used 100 ml, Saindavalam at 12 gram, Varunadigrita 80 ml, Madanapala Churna was added 1 pinch or just 1 gram, along with Kalka, that is Puga Trim Churna itself we made into Kalka. Same Churna only was used for preparing the Kashaya, and Amritasara, that is Gomutra, was added. So one more Basti which we had done was in cases of obesity was green tea Basti. So green tea, is given internally. So green tea, what if we give it in rectal administration? So green tea itself we made same preparation. Madhu Saidosneya Kalkakovata is the same protocol which we use for Basti preparation. Only thing we changed was the Kashaya we used was green tea. As you know, tea itself is nothing but a Kashaya preparation. So why not try green tea in Basti? So we had used green tea for Basti, and it was used for the hyperlipidemia cases. So next is, I would like to highlight the article which was that is on hypothyroidism and Sharavasti. So it is a patient of RA for 1 year and was subclinically diagnosed with hypothyroidism. So here when Sharavasti was administered in Yogavasti schedule, TSH reduced from 31 to 16.6 in 10 days of treatment, and after with follow-up medications, it was reduced to 5.76. So next is on the Nasya and hypothyroidism. So where do we require Nasya? Nasya is indicated for Urdhva Vikara. So where in hypothyroidism it is going to be related? As I said, secondary hypothyroidism is caused because of pituitary gland. So where there is a cases of secondary hypothyroidism which is caused because of pituitary gland dysfunction, there Nasya Karma can be done. As we know, Nasa is Shirsadwara, and the best way to eliminate the doshas which are situated in the Urdhvanga is through Nasya. We can either go for Avapidana Nasya, Mashra Nasya, Pradam Nasya, and can be given there only if the Urdhva Tatrugata, Kapadushti and Shirogaurava, such as hair fall and all these conditions, depression, in all these conditions, you can go for Nasya Karma. Although it is relatively less explored, because we usually do not go for the when patient admit ஆகும்போது கொஞ்ச நேரத்துல நம்ம எப்ப எல்லா சோதனையும் ஒரே நேரத்துல பிளான் பண்ண முடியும். So usually during discharge we go for Pratimash Nasya Karma. So Nasya Karma is mainly indicated where because there is Sanchita Mala in the Urdhva Trigata Vikara for Indriya Bala, Mano Bala. Some of the usually used medicines are Anuthaila and Gudanagara Nasya, which is Avapida Nasya. So Nasya and hypothyroidism. So here there was one of the articles where they have used customized management of hypothyroidism through Ayurvedic intervention, where they have mentioned that is Anuthaila was selected for the treatment of hypothyroidism as it is an Urdhva Trigata Vyadhi along with Panchakarma, Shamana Chikitsa like Arogyavardhanati, Kanchanaragul, etc. were advised for the disease. So here what they have used was these were the Shamana medicines which were used. Along with that they had given Anuthaila for Pratimashanasya. So here TSH reduced from 6.35 to 4.65. So what are the Bahya Upakramas? So Ella Shodhanam Panitra, what about the Bahya Upakramas we are practicing? So these are the procedures which can be combined while doing Basti Nasya. So Udvartana, Dhanyamladhara, Takradhara, Kashayadhara, all these are Rukshana procedures which can be done. So the labor which you see over there, so this was one of the condition patient where there was inflammation of the thyroid gland. So usually most of the labors which are indicated in Vata Jagalaganda, Kapha Jagalaganda and Medha Jagalaganda has been told in Charaka. Whereas here we tried with something of a yukti. It kind of worked, but I would like to highlight what we did was we took Kanchanara, Pushpa as well as the leaves. Both of them were crushed and we made into labor and applied. Actually, it was surprising that it actually reduced the swelling. Just Kanchanara, Pushpa, Patra and milk was used for preparing this labor and applied to the patient. So next is about the Svedana Karma. So usually Svedana Karmas, since it is a Kapha and Vata predominant condition, so initially Ruksha Sveda should be done, followed by the Snigdha Svedas. So Bashpa Sveda, Churna Pinda Sveda, Parishega, Patra Pinda Sveda. So all the first three Svedas are Ruksha Svedas, followed by that we will go for the Snigdha Svedas such as Patra Pinda, Shastik Shali. So here I would like to give a small summary of the Shodhanas which can be done in hypothyroidism. So when there is Vata Kapha involvement and there is Raksa Rakta Dushti involvement, dry skin, cold intolerance, then we will go for Snehana, Svedana, Virechana. Snehana can be done with Kalyana Grida, Mahakita Grida, Kumara Grida, all these conditions. So just a summary table of whatever I have mentioned. So in which dhatus involved, which type of Basti or Virechana, which type of Vamana can be taken. So based on the symptomatic approach, this is nothing but a symptomatic approach. So if there are menstrual irregularities, then you will go for Basti, which you can go for endomolary Basti or with Anuvasana Basti, Dhanvanthra Thaila, Bala Thaila, Nirgundi Thaila, these can be given. When there is generalized weakness and all, then you will go for either Kosha Shodhana, that is Sadhya Virechana, followed by Basti Karmas are given. Some of the Brahmana Bastis also can be given. So Shamana Aushadhis which are commonly practiced in hypothyroidism, which we already know. I would like to not take much time in explaining this, since we still have hyperthyroidism left. Already it is 45 minutes past. So what is hyperthyroidism next? So how is hyperthyroidism? So even though we see some of the cases, 90% of the cases we see are hypothyroidism. Hardly 10% of the cases which we see are hyperthyroidism. So how is hyperthyroidism related? So the basal metabolic rate is very high in hyperthyroidism. It could be correlated to the condition of Tikshnagni, which is Tikshnagni is Pitta Pradhana and does Ashupaka. So due to this condition, Agni, the Samana Vata and Pachak Pitta undergoes Vriddhi and Kleda Kapha goes into Shaya. So Pitta and Vata Vriddhi occurs and there is Kleda Kapha Shaya, which is similar to the symptoms which are seen in hyperthyroidism. So same lakshanas, I'm just trying to correlate Pitta Vriddhi lakshanas like Shuttrit Daha, Alpanidrata, which are seen such as increased appetite, heat intolerance, increased thirst, reduced weight. Basmata Roga, which is explained also as Swasa Krishna Shuddha with the Balahani Daha Murcha, which are seen in hyperthyroidism. So same as how when it affects each and every dhatus, what are the symptoms usually seen? So when there is Rasa Dhatu involvement, usually we have increased appetite, heat intolerance. Rakta Dhatu we have hot flesh, warm skin. Mamsa Dhatu we have muscle weakness, goiter. Veda Dhatu there is weight loss. Asti Dhatu there is osteoporosis. So similar symptoms which are seen. So treatment is same: Shodhana, Balya, Brahmana and Rasayana. So what are the Panchakarma which we are taking? So here we know these are the symptoms and usually the symptom which is seen in Pitta Vriddhi, Vata Vriddhi, Kapha Kshaya, multiple sources involved. So can Vamana be advised in case of hyperthyroidism? No, because there is Kapha Kshaya already in this condition. When there is Kapha Kshaya, you cannot go for Vamana. Even if you give Vamana Aushadhi, it will go for Virechana Karma only. Because there is Alpa Kaphata in the Amarshaya. When there is Alpa Kapha in the Amarshaya, naturally even if you give Vamana Aushadhi, it will go for Virechana Karma. As Vamana Aushadhi and Virechana Aushadhi, both have the same gunas only. If you look into the gunas, if you see, all are having Bhushna, Tikshna, Vyavai, Vikasi guna. There is no change in Vamana and Virechana. Only the Mahabhuta predominant. That is Vamana Dravyasa, Akasha and Vayu Mahabhuta predominant. Hence they go Urdu Jatragata. Whereas Virechana Dravya, sir, no, they are Prithvi and Jalamahabhuta predominant, which are heavy. Henceforth, they go Adogati. So next is Snehana. So we can go for 3 types of Snehana. As you know, one is Shodhananga Snehapana if we are guiding for Snehapana. Otherwise, we can go for Shamananga Sneha. Otherwise, Brahmananga Sneha. So commonly used gritas which are used are Panchatikta Guglu Grita, Mahatikta Grita, Kalyana Grita, Dadimati Grita, Brit Ashwagandhadi Grita, Shatavariyadi Grita. So Sweda and hyperthyroidism. So already it is a Pitta Vritti condition. How can we go for Sweda here? So Tikshna Sweda should be avoided. Rather Mrudu Sweda, Drava Sweda should be given in such conditions. Such as Parisheka Sweda or Dhara, Pilichal, which are form of Drava Sweda, which is somewhat light because since it is already Pitta Vritti condition. So next is Virecha and hyperthyroidism. So general indication and contraindication should be kept in mind. Durbala and Atikarsha should be avoided. Otherwise, you can go for Avara Shuddhi. Thus, Shrota Shuddhi and Vatanalopana. Aushadha and its matra depends on the Koshta Kala Bala of the persons. Vridu Virechana or Nitya Virechana is usually advised in case of hyperthyroidism. So Virechana medicines which can be given are Avipatti Karachurna, Nivamba Amrita Dhyaranathila, Gandharvasaratila, plain Draksha Surasa or Tripala Kashaya. Although the selection of these medicines all depends on the Agni and Koshta of the person. So based on that, you can go for the selection of these medicines. So Basti and hyperthyroidism. So here it is already a Pitta Vata condition. So here we have to go for some of the Brahmana Vastis. That is the most favorite, that is Mustadi Apana Vasti. It is the Shira Vasti where Madhu, Saindava and we have Taila. We can usually go for Shira Bala Taila or any of the Gritas also can be taken for the preparing the Vasti. So here we are using Shira Bala Taila, but you can also use for Duglu Tikta Grita, Panchatikta Grita, Mahatikta Grita, any of the Grita because Grita is Pitta Anilahara. It will have more benefits. Even Kalka, the same Mustadi Apana, whichever they have already described in that. And then Kashaya is Mustadik Shirapa. Madhutalika Vasti. Madhutale Samasana, Pata Sharana Muda, Paladam Satapuspaya, Tatavardam Sendavasya. Palena Ekana Sayukta, Kajana Vilodita. So Madhutalika is also one of the most commonly used preparation, where Madhu is 200 ml, Saindava is 12 gram, Thaila is taken as Madhu and Thaila should be taken in equal quantity. Shatapuspa is the Kalka, and Endamola Kvata plus or minus Shira. So Endamola based on the Yukti of person. So initially 3 days you can go for plain Endamola Vasti. Then you can slowly start with Brahmana Karma where you can add Ava plus Shira or you can prepare Endamoladi Shira packets. So next is Manjistadi Shira Vasti. So this does not have any classical preparation, but it is one of the Vastis which because Manjista has Pittara. So hence we prepared like one of the Vasti Churnas which is currently being used in our clinic where we are using Manjistadi Chara Vasti as well as Manjistadi Shira Vasti Churna. Both we are using practicing for avian cases. So here Makshika is 100 ml, Lavan is 12 grams, Grita is 100 ml, and Guduchi Estimadu Manjista is taken as the Khalka Dravya, and for Kashaya Dravya we are using Estimadu Kshirapaka or Manjistadi Dravya which we have a combination with Kshirapaka. So another one is Ardhamatrika Vasti. Why I am highlighting Ardhamatrika Vasti here is it is one among the most underrated Vastis which everyone is already practicing but they do not know about it. Ardhamatrika Vasti is nothing but Dashamola Kashaya Vasti. Okay. Ardhamatrika, why it has been told is it is the only Vasti which is given exact half of the Dwadasha Prasritika Vasti. It is only half the dosage. The highlight of Ardhamatrika Vasti itself is I have told the Palastras that is Nacha Sneho, Nacha Svedo, Parihara Vivardina. That means the Vasti can be given without Sneha, without Sweda. The person who is taking this Vasti no need to follow any of the Pariharas. So that is the importance of Ardhamatrika Vasti. So this Vasti can be even practiced at OPD level practice itself. Okay. So also highlighting they have told Sarva Roga Nivarana. Nacha Sneho, Nacha Svedo, Parihara Vivardana, Acharya Anumati Desha, Ardhamatrika Sarva Roga Nivarana. It is indicated for all the disorders. Specially indicated Exmagnasta Shulagasha, Exmagnasta Shulagasha, Kribignasta Visheshataha, Shukra Sanginana Desha, Pumsavanaha Paraha. So it has been told to increase the Shukra as well as indicated for Pumsavana Paraha also. So in such type of Vastis can be given when there is even Shukra dosha involvement because of hyperthyroidism. So that is why I said Vastis is the only treatment where when there are multiple complaints, only one Vasti, it is the yukti of the physician to select the Vasti. One Vasti can cure all the symptoms which are present in the patient. So coming to Nasya and hyperthyroidism, can be done as Marsha Nasya, Pratimarsha Nasya, can be performed with Brahmana Dravyas like Shira Balataila, Dhanvanthra Gunana, Brahmi Grita, Mahakalyan Grita, all these are having Pitta action. So you can go for any of these Gritas or Thailas for Nasya Karma. So Bahir Parimarjana Chikitsa, we can go for all the Brahmana therapies like Abhyanga, Shtik Shali, the Thailadhara, Shiradhara, Thalapodisham, Shiropiji, Shirotaram can be done. And all the Shamana Oshadhis which are usually given, which are Pitta and Vatara, which are like what is like Kamaduga Rasa, Shuta Shekhar Rasa, Pravala Mancha Prata Rasa, then Kashayas like Guruchi Adi Kashaya, Patala Katra and Pugim Padikada. Rasayanas, you can go for Amlaka Rasayana, Savana Prasha Leha, Ashoga Tavaliha, Asava research like Saraswata research, Gritas like all the Tikta Gritas, which I have already mentioned, can also be given for Shodhananga, Shamananga as well as Brahmananga Sneha. It is only the duration of time which we are administering matters for the which type of sneha it is going to work. So coming to one of the most important questions, that is scheduling of anti-thyroid and pro-thyroid medication during Panchakarma. So now patient has come and already he is on thyroid hormone, but can we stop it immediately and go for sneha bana? So during sneha bana, already patient we are giving in empty stomach only, we are advising the patient to take Grita. So during Snehapana, can we stop thyroid medication? Absolutely not, because we cannot stop it immediately. So even the American Thyroid Association recommends that levothyroxine should be consistently taken 60 minutes before breakfast. So what protocol usually we are following is after the Sneha Jirna Lakshanas are attained. So once the Snehapana is administered, we wait for the Sneha Jirna Lakshanas. That is Shiroru, Brahma, Nishtiva, Klama, Sada, all these indicate that sneha is getting digested. So once these lakshanas start to subside and the patient starts to get deepana of the agni, only then after the sneha jirana, before the administration of food, the patient can be given thyroxine medications. So this should never be stopped immediately, whereas you can start to taper the medication dosages only after the samsarjana karma is completed. So after the samsarjana karma is completed and the patient starts to take the shamanaushadhi and let us maybe Kanchanara Gugulu or any of the patent medicines which are given. So after that, slowly we have to take 3 months continuous follow-up test of the TSH, T3, T4 levels. Once that starts to decrease or when we start to see the improvement, only then we can slowly taper the dosage. That is, if the patient is taking 100 mcg, we can slowly taper it down to 75, then come down to 50 in the course of 1 year, never before that. In the course of every 3 months with constant evaluation, the doses have to be tapered down. So there is no standard protocol. So because in those times, Acharyas never told that you can take this, because one of the most common controversy, even liver doctors, which is talking about Ayurveda fraternity, is concomitant medications. We are not stopping modern medicine also, we are not stopping Ayurvedic. So could there be concomitant medication effects? So will there be synergistic or antagonistic reactions? We need more studies to really discover those things which are being discussed. So my advice is to slowly start to taper down the medications rather than stopping it abruptly. So next one is case report. So here I have 3 cases which have in hand see. So here one is a female patient of 37 years who had weight gain since 2 months and hair fall since 2 weeks, coldness, associated with heaviness and body pain and backache. So here this was the general examination you all see. So here it's a known case of hypothyroidism. So here what was the treatment which we were given was on Sarvanga Udvartana and Sarvanga Parishega, which is Rukshana, which was given for 5 days. Followed by that, we had started with Eranamodadik Sharavasti, where Anuvasana was given with Brihad Sandhavaya in a modified Kalavasti schedule. So modified Kalavasti schedule means here we give Sneha, Kashayavasti in the morning, Snehayavasti in the afternoon. So both are given on the same day itself. Since it is Eranamodadik Sharavasti, if we give 1 day itself, then we cannot let the patient to stay on the same day in empty stomach, because there will be high chance of Vata Prakopa because of the Ruksha Karma which we are doing. So henceforth to subside that, we have to go for Snehavasti in the afternoon itself. So when we are usually going for Sharavasti or selection of any of Lekanavasti, it is advised to give Snehavasti on the same day afternoon itself or immediately after food. So here we are going for Udvardhana Parisheka, that is Rukshana of 5 days, followed by the Eranamala Sharavasti, Sarvanga Parisheka, which was done for 3 days because only plain Kashaya Parisheka with Dashamala Kashaya was done. Whereas patient had already low back pain, so Kadibasti with Nirgundi Thaila was also done. So what was the thyroid profile before and this was the thyroid profile after. So TSH was 100, which was reduced to 84. T4 was 8.8, which came down to 7.18, and when T4 was T3 was 100, which reduced to 84. T4 was 8.8, which reduced to 7.18. TSH was 9.58, which gradually reduced to 5.20 immediately after the treatment itself. So here follow-up medicines, nothing was given. Only after 14 days of basti we had gone for the test. So next is another case where 37-year-old female patient who was complaining of heaviness, body lethargy, gradual weight gain since 10 kg since 3 months, complaints of dyspnea, exertion since 4 years. She is a known case of hypothyroidism, already under medication of Thyronorm 75 mcg. So here first we had gone for Deepana Panchana initially. Treatment given was tablet Chitrakadivati was given 1 PD before food. Aduthaila was given Nasya for Pratimatra Nasya, and Pipali Churna was given 5 gram before and morning and evening after food. So here what the IP treatment we had given was, first we had gone for Sadhya Virachana, or we have called it as Koshta Shodhana. There is no karma called as Sadhya Virachana. There is only Sadhya Vamana which exists, which is told in Charaka Chikitsa, 3rd chapter Jwara there. There is no reference for Sadhya Virachana. It is simply called as Koshta Shodhana. So Koshta Shodhana with Avipatikara Churna 25 gram with honey is given. Followed by that, so after we had given the Koshta Shodhana, next it is time for administration of Vasti. So we had gone for Vaitarana Vasti with Vaitarana Vasti, which was given in Yoga Vasti schedule, and Anuvasana Vasti was given with Varuna Adhikrita. So on discharge, we had given medicines such as Shraddhana Yoga Vati, Kanchana Goblu, Varuna Adhikashaya, and Avipatikara Churna, just for Nitya Virachana purpose. So the patient's weight was reduced from 88.9 kgs to 82.3 kgs. TSH reduced from 39.5 to 25.2. So this was during a how many months period? So almost 5 months period where they had, after undergoing Shodhana Chikitsa and Samsajakrama, where they had taken the Shamana medicines. So next is case 3. This is the case of hyperthyroidism. So hyperthyroidism, I could not find much articles also about it because rarely we get such cases about this, and we do not have exact proven methodologies. So here, 31-year male, so increased sweating, increased appetite, reduced sleep, burning sensation was seen in bilateral palms, ulceration, and weight loss of 8 kgs in 2 months was seen. So TSH was reduced, T3, T4 was increased, so known case of hyperthyroidism. So treatment given was just, here we had gone for only Shamana medicines. No Shodhana was chosen because already weight loss was there and patient was not building Alpa Bala of the patient. So henceforth we will not go for admitting the patient. So instead we chose to treat him with Shamana medicine. So here we went for Kamadoga Rasa, 2 BD after food. Then Stomatar capsule was given 1 BD after food. And then Draksha Dikasha was given 30 ml TAD. And Freelax capsule for Adalomana purpose. So this was the result which was seen. So before treatment it was 0.1 TSH improved to 1.74. T3 397.99 improved to 131. T4 which was 24.48 reduced to 5.917. So reduction of the symptoms were seen by 50% in hyperthyroidism patients. So after highlighting all this, I have to tell about the limitations of Panchakarma. So in cases of congenital diffuse goiter, in iodine deficiency goiter, already if you give salt which is present with iodine deficiency goiter is going to get managed. So here, and thyroid toxicosis. In these conditions, I have not seen any of the Panchakarma which is being practiced, although based on the Yukti we can further develop. So some of the clinical studies which are currently done was an open label single arm clinical study on the combined effect of Chitrakadivati and Avipatti Churna in the management of hyperthyroidism. So here Chitrakadivati was given BD for 90 days and Avipatti Churna was given for every 3 months. The patient had, for every 3 months patient had to take 1 day of Koshodhana with Avipatti Churna. For every 30 days. So, for every 30 days, that is every month, he had to take once Koshodhana and regularly he had to take Chitragadivati. So, results in this was shown that combinations of reduction in TSH levels and increase in T4 after 90 days. So, it will take some time if I start to explain this also as a case study. So, I will share these articles in the group. So, clinical studies are another study which was used was Vadavanala Churnavati. So, Vadavanala Churna is nothing but the combination of Panchakola. Pipli Pipli Moola, Chavya Chitra Kanagara mixed with Saida Vadavana is nothing but Vadavanala Churna that they had made into Vati form and used in hypothyroidism. So here the principal individual is Dr. Meghana, who is one among the KC fraternity over there. So they had tried this in their research medicine. So here 2 PAD was given. So reduction, so using this medicine for 45 days showed reduction in TSH levels and improvement in T3 and T4 was seen. So what I would like to conclude is that Panchakarma offers a holistic, individualized approach for the management of thyroid disorders. Procedures like Pamana, Virechana, Basti, Nasya, all of these help in balancing the Agni, regulating the doshas, improving the Dhatu status. So Ayurvedic management not only aims to control symptoms, but it is aiming to reduce the root cause level at the level of Agni and Srotas. So now let's come to what I said about gut dysbiosis and Panchakarma. So here this was one of the articles where they had said clinical study on Virechana Karma, therapeutic purgation over the gut flora with special reference to obesity. So here they had shown that Virechana is effective in the management of obesity as it helps to reduce the colonization of the aerobic bacteria. So after Virechana Karma, follow-up was taken. So Virechana Karma, before Virechana Karma, they had taken a stool sample, checked the aerobic bacteria which is present in the intestine. So after Virechana Karma, the stool was taken and checked for the aerobic bacteria. So it showed there was a complete change in the microbiota which was present. So here this study was mainly focused on obesity. Rather, what we would like to take a gist from this is that the Shodhana Karmas are altering our gut microbiota. So henceforth, that is why our acharyas have told what is the benefit of Panchakarma. Evam Vishuddha Koshtasya Kayagni Abhivardhate Vyadesya Upashamenti Prakritischa Anuvartate Indriyani Manobuddhir Varnaschasya Pritidati Balam Pushtiram Apatyam Cha Vrishadhasasya Jayate Jaram Prithvena Labate Chiram Jivati Anamya Tasmat Samsodhanam Kale Yukti Yukta Tribenara Evam Vishuddha Koshtasya. Vishuddha Koshta means it is Shodhana of the Koshta. Shodhana of the Koshta is nothing but cleansing of the gut, which is improving the gut microbiota, which is present in our that is in our GIT. So as I said, GIT, which has the gut microbiota or the gut dysbiosis, is the main root cause for the autoimmune disorders. And Panchakarma is helping in treating the gut microbiota or the gut dysbiosis by altering them, and henceforth that is why Panchakarma or what we say detoxification procedures are helpful in treating the autoimmune disorders. So these are some of the references which I have taken to finish my presentation, and I would like to especially thank my team of doctors at Dhanvanthri Premils for helping me collect all the information and managing the duties while I could finish my presentation as well. Thanks to my father for his constant motivation. Thanks to my guru, Dr. Ashwini Kumar, for teaching me Panchakarma and making me understand it to the best. Thank you so much.
Thank you so for your presentation. I request Dr. Ramesh sir and Dr. Sanjeevi sir to felicitate our speaker.
కొంచెం బ్యాక్ లో అవును విశాఖ లైట్
Question கேக்குறீங்களா? No mic. சரி, question. பேசுறது கேக்குது.
Actually, the common think once Panchakarma is something like a magical cure. Once in a lifetime, it is not like that. Panchakarma is not a magical remedy which you can give one time. Actually, Acharya have told Puna Shodhana. It is repeated use of the Panchakarma and Shodhana karmas to be done. It is not after one time we can completely stop levothyroxine, completely reduce thyroid, it will never aggravate. It can re-aggravate. It is similar to how we treat like fever. Once if you give Dolo or any paracetamol, doesn't mean that it will never reoccur again. Or if the nidanas and everything happens, there is a chance of relapse. So similarly, when there is a change in the gut microbiota, maybe because the patient starts to follow the same old nidanas again, there may be alteration in the GI, which may lead to again gut dysbiosis, which may cause the same conditions. So it is not once if you take Panchakarma, there will be only reduction. So there will be reduction if the patient follows the procedure as well as followed by the Patya which is in place.
Leptospirosis.
Yes, yes, sir. So leptospirosis is actually one of the things. But if you look into Gomutra, it has nitrogen, urea, and everything. So what we actually do is Amritasara, which I was telling you, is not Gomutra directly. So for the current times, actually, thank you, sir, for pointing out. Gomutra we are using in the form of Arka. So here what we are doing is Gomutra Arka is made. So that is why what we are doing is it is a complete distillation process of the Gomutra. So here when you are heating as well as condensing the Gomutra, we are removing all the bacteria which is present in it, and only the complete form of that is the Arka form is taken for Vasti preparation. So what is the main highlight in this is when we are using Arka form, the potency is also increasing, as well as we are able to retain the same properties of Gomutra directly. Thank you, sir.
Ardhamatrika Vasti சொன்னீங்க.
Yes.
அது time duration அந்த மாதிரி.
Ardhamatrika Vasti actually it is supposed to be given similar to Neurovasti. That is when there is no hunger or complete after digestion period. So usually it can be given in the early morning or 3 hours after digestion of the previous food. That is when there is empty stomach or complete digestion of the previous food. Parihara Vivardhana means what Acharyas have told us. Parihara for the patient. So immediately after Vamana or Virechana or immediately after Vasti, usually what the patient has to follow is they have to stay in Nivatasthana. They should take only Anabhishyati, Ushna, Laghu Bhojana food should be given. But instead, these all need not to be followed. Like usually we say patients should not travel immediately after taking the Vasti because Vata will increase when you are doing any of the Jagrana or anything. So here all these Pariharas need not be followed for Ardhamatrika Vasti. There is about a time. According to the patient, it should be given immediately, not immediately after food like an hospital. Rather, it should be given like normal Neurovasti schedule.
Maximum எவ்வளவு நாள் கொடுக்கலாம்? Maximum எத்தனை நாள் கொடுக்கலாம்?
Usually, that is what we can usually give Ardhamatrika Vasti எல்லாமே வந்து நம்ம யோக வஸ்தி or கர்ம வஸ்தி or கால வஸ்தி schedule தான் plan பண்றது. Usually till the Samyak Nirvalakshana certain.
Continuous கொடுக்கலாமா
that's what it depends on the patient condition. Suppose if the patient is of Kapavata, he is having Kapavata condition like Kapavata the Gridrasi, then you have to go for Yoga Vasti schedule. If there is Pitta Vata involvement like Vadarakta or something, then you have to go for Kala Vasti schedule. If there is Kevala Vata journey, then you have to go for Karma Vasti schedule, which is 30 days.
Matra means Anuvasana Vasti necessary.
Yes, Anuvasana Vasti is necessary. Only in Shira Vasti and Brahmana Vastis, it is not compulsory to give Anuvasana Vasti because already the Vasti itself contains Shira and everything, which will lubricate the gut and which is already providing enough Brahmana. We do not need to go for Anuvasana Vasti. Whereas in Vadarakta, if you see, they have given Sagrata Shira Vasti, where Sagrata Shira Vasti, if you administer, you don't need to administer any of the Anuvasana Vasti itself.
retention எவ்வளவு நேரம்?
Usual retention, two methods of Basti usually now we are practicing. One is enema can method, another is Basti Puttaka method. So Basti Puttaka method, if you are administering, usual classically it's for 1 month, but usually we see for around 20 to 30 minutes. But initial first few days, what we see is the retention is around 10 minutes, 15 minutes. It gradually increases for the patient. When we are going for Puttaka method, when we are going for can method, it is only 2 to 3 minutes. So highlighting, thank you for highlighting this. So there was one case, one research which was done on these two methods itself. Puttaka method, that is Puttaka method, Basti Puttaka method and can method. Is there any difference in these two methods? So what was seen in this study was only the retention time was changed. Retention time was changed because Puttaka method we are giving Pidana, we are doing Pidana and we are giving pressure. So henceforth what happens, the Basti Dravya travels from the descending, that is from the descending sigmoid to descending to transverse to ascending till almost reaches till the ascending column. Whereas when we are giving just the can method, because of the lateral position, it will only reach up to the flexure of the sigmoid column. So these two differences were there in the retention time. But was there result difference in the patient? Was there any result difference? If you see, both the Bastis when administered showed same results only. Result same now. Whether the Basti of the patient was given, actually it was a case of Gridhrasi when they were given. Gridhrasi case ke Puttaka method la koduthala same result da vanduchu. Enema can la koduthala same result. Only the difference was in the retention time.
Actually, நம்ம எப்படி டிசைட் பண்றோம்? நிருகவஸ்தி itself துவாதச பிரசவ வஸ்தி நம்ம சொல்றோம். அந்த மாதிரி வஸ்திக்கு நீங்க கரெக்ட்டா வந்து அந்த அந்த மாதிரி நீங்க கொடுத்தீங்க. பாக்கி இருக்கக்கூடிய எல்லா வஸ்தியுமே வந்துட்டு குவாண்டிட்டி
has been reduced.
அந்த மாதிரி தான் இருந்தது.
Because
இங்க வந்துட்டு நம்ம நிருகவஸ்தியோட அந்த full dosage கொடுக்கிறது. இந்த dosage வந்துட்டு துவாதச பிரசவமா இருக்கும்போது அந்த ரிட்டென்ஷன் எப்படி இருக்கு? அல்லது இப்போ நீங்க கொடுக்குறீங்களா ஒரு 4 நடக்குது. அதுல ரிட்டென்ஷன் எவ்வளவு இருக்கு?
Yeah, actually what sir is saying is correct because actually classically it has been told Dwadasha Prasantika Vasti, which is approximately 1200 ml. But all the correct Vastis which we are practicing are 600 ml. Which we had, everyone has a doubt about this. The reason it could be that the pramana of the humans which were present during our acharyas could have been different, where the size of their Bakvashya was different, which could be able to accommodate such amount of Vastis. Whereas I have actually practiced one of the Dwadasha Prasantika Vasti. But how we gave this Dwadasha Prasantika Vasti was, we gave it interval periods. So what we are kindly looking for in the patient is Samyak Nirvalakshana. That is, Prasishta Vidmutra Samirata, Ruchya Agni Vrudyasha Ragavani, Rogopashanti Prakrasisanta, Tada Samyak Nirvasya Lakshana. So what we are looking for is Samyak Nirvalakshana. So till Samyak Nirvalakshana, we have to give Vasti means. Why you stop with one Vasti on one day? So first give 400 ml. Next, once he is fast, again go for administration of another Nirvasti. So similarly, Sushruta has told you can administer 4 Nirvasti in one day itself. So if you administer 3 times 400 ml, it comes down to Dwadasha Prasantika, 1200.
hypothyroidism ectosis நிறைய ஸ்கில் அது எப்படி மேனேஜ் பண்ணலாம்?
So ectosis or dry skin, if dry skin is related, it is probably apart vata which is affecting the rasa vata dhatu. So here we can go for internal skin. If the hypothyroidism, first we have to assess the agni of the patient. If the agni of the patient is brought to normal, then we can go for internal administration of any of the Shamadanga techniques. Either Siddha Grindha can be given or Madhita Grindha can be given. Externally, we can go for the application of any of the oils, like any of the oils that is already we know Sneha will reduce the Rupsata. So any of the oils can be used for external application. Thank you.
அது சொன்னார்ல இது கோமத்துல
கேட்க வரல. இவங்க அப்ரிஷியேட் பண்ற மாதிரி 2 பேருக்கும் ஒரு ஸ்டாண்டிங் ஓவேஷன். Both sessions are very informative and being his first performance in Madurai. Wonderful sessions, very informative.
Thank you, sir. இது நான் சொல்லாம சொல்லிட்டாங்க. I am very very happy. Please எல்லாரும் உட்காருங்க. எனக்கு ரொம்ப சந்தோஷம். ஏன்னா இந்த செகண்ட் CME ப்ரோக்ராம் ஸ்டார்ட் பண்ண உடனே கண்டிப்பா நியர்லி ஒரு 10 days ஆச்சு. ஒவ்வொரு நாளும் எல்லாத்தையுமே கூப்பிட்டு பேசிட்டே இருந்தேன். வாங்க வாங்க வாங்க. கஷ்டப்பட்டதுக்கு I am very happy. எனக்கு 2 பேர் கிடைச்சிட்டாங்க. ஸ்டேட் லெவல்லையும் நேஷனல் லெவல்லையும் பண்ற அளவுக்கு நம்ம மதுரை டீமுக்கு 2 பேர் கிடைச்சிட்டாங்க. ப்ளீஸ் எனக்கு இது 2 பேர்த்தையுமே டாக்டர் விஷாக், டாக்டர் மகாலட்சுமி நாங்க அடாப்ட் பண்ணிக்கிறோம். வெரி நைஸ், மோர் இன்ஃபர்மேட்டிவ், வெரி ரொம்ப மோர் இன்ஃபர்மேட்டிவ், நிறைய விஷயங்கள் ரொம்ப சந்தோஷமா இருந்தது. ஐ எம் வெரி ஹாப்பி. அப்புறம் இது பர்சனலா சொல்றேன், தன்வந்திரி நிலையத்துக்கு, தன்வந்திரின்ற ஒரு கிரீடத்துக்கு வைரக்கன். அப்புறம் திருக்குறள்ல வந்து ஈன்ற பொழுதிலும் பெரிது வைக்கும் தாய், சான்றோர் நினைக்கிற தாய் அப்படின்னு சொல்லுவாங்க. அம்மா வந்து அங்க இருக்காங்க, அப்பா இங்க இருக்கிறாரு. கன்னி பேச்சு ஃபர்ஸ்ட் தந்தை முன்னுக்கு இன்னைக்குதான் முத அப்ப இன்னைக்கு ஃபர்ஸ்ட் தடவை இன்னைக்குதான் பாக்குறாங்க. வெரி நைஸ், ரொம்ப நல்லா இருந்தது. தேங்க்யூ. ப்ளீஸ் நீங்க அது அவருக்கு அண்ணா
Thank you, thank you, thank you. There's no words to say. அவர் வந்து விஷாக் வந்து ராஜீவ் காந்தி யூனிவர்சிட்டியில 7th rank. தமிழ்நாடோட கர்நாடகா பத்தி கேள்விப்பட்டிருப்போம். பயங்கர காம்படிஷன் சைட். அப்ப அவ்வளவு சொல்லும்போது கூட நான் இதுவரை அவர் கிளாஸ் எதுவும் அட்டன் பண்ணதே இல்லை. எனக்கு ஒரு சான்ஸ் அங்க போய் பார்க்கறதுக்கு வாய்ப்பு இல்லை. அவங்க பிரின்சிபால் ரொம்ப என்கிட்ட சொல்லிட்டே இருப்பாங்க பர்சனலா, why doctor you are not coming to this meet one time when he is attending a class. Time இதுல எஸ்கேப் ஆயிட்டே இருக்கேன். நான் போனதே இல்லை. ஃபர்ஸ்ட் டைம் I'm seeing. I'm really thanks. அதை விட குரு சொல்லிக்கிறது ரொம்ப சந்தோஷம். இன்னைக்கு ஹரின் சார் வரணும்னு கேட்டது நான் ரமேஷ் சார் தான் சொன்னேன். என் பையன் ஃபர்ஸ்ட் டைம் பேசினான். பட் இருந்தாலும் என்னோட குரு வந்து உட்காந்து பார்த்தா ஐ வாஸ் வெரி ஹாப்பி. சந்தோஷப்பட்டேன். சார் இன்னைக்கு நிறைய ப்ரோக்ராமோட சேர்ந்து இதை பிடிச்சிருத்து வந்துட்டேன். அண்ட் தேங்க்ஸ் டு இளஞ்சலியன் சார் அண்ட் அருண் ஸ்டேட்ல இருக்காங்க. எல்லா நம்ம மதுரை மெம்பர்ஸ் எல்லாத்துக்கும் தேங்க்ஸ். really mesmerized. நான் ரொம்ப நேரம் யூஸ்வலா எந்த கிளாஸ்ல நான் உட்கார்ந்ததே இல்லை. நானும் பர்சனலான்னு சொல்லிட்டு ஜோலி பெறுவோம். ஒரு சிஎம்ல கூட எல்லாமே நடத்துவோமே தவிர ஒரு சிஎம்ல நானும் அவங்களும் உட்கார்ந்ததே கிடையாது. தேவகாரமும் நான் அரியன் சார் ரொம்ப சீரியஸா இருப்பேன் சார். அந்த வந்து சிறப்பு சொல்லி போயிருவோம். இந்த ஒரு சிஎம்ல தான் நான் எனக்கு ஃபுல் அண்ட் ஃபுல்லா இருந்து பார்த்திருக்கேன். அண்ட் தேங்க்ஸ் டு மகாலட்சுமி ஆல்சோ. ஏன்னா 2 பேருமே எஸ்பிஎம் ஆமா அடாப்ட் பண்ணியாச்சுங்க. அதனால 2 பேருமே எஸ்பிஎம் ப்ராடக்ட். So I think that எல்லா கிரெடிட் கோர்ஸ் டு ப்ரொஃபசர்ஸ், டீச்சர்ஸ். ஏன்னா ஒரு டீச்சர்ஸோட வேல்யூ அவங்களுக்கு தான் தெரியும். கிளாஸ் எடுக்கும்போது அந்த ஸ்டூடெண்ட் மறுபடியும் அவங்க பிரசன்டேஷன் கொடுக்கும்போது ஆமா கரெக்டாக 4வது ஜெனரேஷன்லங்கிறதுல. ஸோ தேங்க்ஸ், தேங்க்யூ ஃபார் யுவர் கான்ட்ரிபியூஷன்.
ஸ்பெஷல் தேங்க்ஸ் ஃபார் ஸ்டேட் செக்ரட்டரி, ஸ்டேட் பிரசிடென்ட் அண்ட் செக்ரட்டரி இன்னைக்கு வந்திருக்காங்க. நம்மளுடைய வேண்டுதலை ஏற்று வந்திருக்காங்க. அது மட்டும் இல்லாம இந்த மதுரையோட ஃபர்ஸ்ட் CME ப்ரோக்ராம்ல இது வந்து லைவ் டெலிகாஸ்ட் ஆகிட்டு லைவா போய்கிட்டு இருக்கு. அதே நாள் சீரீஸ்ல வந்து நம்ம எப்ப வேணாலும் பார்த்துக்கலாம். எனி டவுட் எதா இருந்தாலும் நேரடியா பார்த்துக்கலாம். ரொம்ப சந்தோஷம். ப்ளீஸ் டாக்டர் இளஞ்செழியன் ஸ்டேட் பிரசிடென்ட், டாக்டர் அனுபவன் ஸ்டேட் செக்ரட்டரி.
தூரம் வந்திருக்காங்க.
திட்டிட்டு இருப்பீங்கன்னு நினைக்கிறேன். சாப்பாடு ரெடியா இருக்கு. இந்த நேரத்துல மைக்க கொடுத்துட்டீங்க அப்படின்னு. சாரி, ஒன்லி ஜஸ்ட் 5 minutes மட்டும் எடுத்துக்கிறேன். எப்படி மதுரைன்னா எப்படி மீனாட்சி அம்மனோ எப்படி ஜெகர்தண்டாவோ அதே மாதிரி ஏஏசின்னா நமக்கு வந்து நம்மளுடைய ஆனரரி பிரசிடென்ட் பிரேமண்ணா தான். பிரேமண்ணாவோட வழிகாட்டுதல் பேர்ல நம்ம நல்லபடியா செஞ்சுட்டு இருக்கோம். அதே மாதிரி நம்மளுடைய குரு ஹரிகரன் சார் வந்திருக்காங்க. அத்தியன சீரியஸ் அப்படின்னு சொல்லிட்டு ஒரு நல்ல ஒரு தொடக்கம் ஆன்லைன்ல பண்ணிக்கிட்டு இருக்கோம். சாரோட தலைமையில அதை நான் பண்ணிட்டு இருக்கோம். சாரோருக்கும் இந்த நேரத்துல வந்து வணக்கங்கள் தெரிவிச்சுக்கிறது ரொம்ப கடமைப்பட்டிருக்கேன். பொதுவாக பாத்தீங்கன்னாக்கா நம்ம ரொம்ப ஒரு ப்ரோக்ராம் அப்படின்னாலே ஒரு 4 பேர் 5 பேர் 10 பேர் அவ்வளவுதான் இருப்போம். அதுலயும் இந்த கொஞ்சம் பெருந்தரைகள் கொஞ்சம் வயசான கேஸ்கள் மட்டும் தான் இருந்தது. ஆனா இப்ப பார்க்கும்போது ரொம்ப சந்தோஷமா இருக்கு. யங்ஸ்டர்ஸ் அதுக்கு ஈக்குவலா வந்திருக்காங்க. அதுக்கு ரொம்ப நன்றிகள். அது நம்மளுடைய மதுரை ஜோனோட பிரசிடென்ட் நல்ல ஒரு தொடக்கம் கண்டினியூஸ் CME பண்ணிட்டு இருக்காங்க. நல்ல விஷயங்கள். அதே மாதிரி நல்ல ஒரு டீம் செக்ரட்டரி யங் அண்ட் எனர்ஜெட்டிக் செக்ரட்டரி இருக்காரு. அது மாதிரி நம்மளுடைய ஸ்டேட்டோட செக்ரட்டரி கூட இருக்காங்க. அது மட்டும் இல்லாம நிறைய பேர் இருக்காங்க. எல்லாத்தையும் சொல்லிட்டு இருந்தீங்கன்னா அவர் வித்துட்டுவீங்க. ஸோ எல்லாருக்கும் ரொம்ப நன்றிகள், வணக்கங்கள். ஸோ இப்போ அடுத்ததான் நம்ம என்ன பண்ணோம்னா, இப்போ நம்ம இதுல கோயம்புத்தூர்ல வந்து ஒரு 2 days ப்ரோக்ராம் பிளான் பண்ணிட்டு இருக்கோம். 8th and 9th August. ஸோ அது ஆயுர் எக்ஸ்போ அலாங் வித் தட் நம்ம ஒரு நேத்திர ரக்ஷா நம்ம ஷாலக்கியத்துல வந்து ஒரு 2 days கான்ஃபரன்ஸ் பிளான் பண்ணியிருக்கோம். ஸோ அதுக்கு வந்து இதே மாதிரி மாஸ் வந்து மதுரை ஜோன்ல இருந்து நீங்க கொடுக்கணும், மாஸ் சப்போர்ட் கொடுக்கணும் அப்படிங்கறத கேட்டுக்கிறேன். அது மட்டும் இல்லாம அன்னைக்கு வந்து நம்ம ஜிபி பிளான் பண்ணியிருக்கோம். ஃபர்ஸ்ட் ஜிபி இந்த டீம் எடுத்த பிறகு ஃபர்ஸ்ட் ஜிபி பிளான் பண்ணியிருக்கோம். அது கோயம்புத்தூர்ல நடக்க போகுது. அது மட்டும் இல்லாம அடுத்ததா வந்து நம்ம ஆரோக்கிய கல்பம் ரொம்ப நாளா செயல்படாம இருந்தது. அது இப்ப ஃபங்க்ஷன் ஆயிட்டு இருக்கு. ஒரு டீம் அது வந்து நம்ம கோயம்புத்தூர் ஜோன் வந்து இனிஷியேஷன் எடுத்து அவங்க இன்சார்ஜ் எடுத்திருக்காங்க. ஸோ அது வந்து பாத்தீங்கன்னா ஒன்லி கோயம்புத்தூர் ஜோன் மட்டும் கிடையாது, எல்லாருமே ஒவ்வொரு ஜோன்ல இருந்தும் ஒரு 1 or 2 வாலண்டியர்ஸ் அவங்க எடுத்துட்டு இருக்காங்க. ஸோ அந்த ஆரோக்கிய கல்பம் இதுலயே பண்ணலாம்னு இருந்தோம். பட் ஆனா அடுத்ததா வந்து நம்ம ஆயுர்வேத டே வருது. அந்த ப்ரோக்ராம் வந்து நம்ம சென்னையில பிளான் பண்ணியிருக்கோம் அடுத்ததா. ஸோ அந்த நேரத்துல வந்து லான்ச் பண்ணும் போது நம்ம மினிஸ்டர் லெவல்லையும் அதே மாதிரி வந்து அபிஷியல்ஸ் நிறைய வரதுக்கு வாய்ப்பு இருக்குங்கிறதுனால அந்த ஆரோக்கிய கல்பம் வந்து சென்னையில வந்து லான்ச் பண்ணலாம் பிளான் பண்ணியிருக்கோம். இதுதான் அடுத்தடுத்த உள்ள ஒரு இனிஷியேஷன்ஸ். அசோசியேஷன் பொறுத்த வரைக்கும் 3 ஜோன் எலெக்ஷன் முடிஞ்சது, நல்லபடியா செயல்பட்டு இருக்குது. அதே மாதிரி மீதி 2 ஜோனுக்குள்ள எலெக்ஷன் நடத்துறதுக்கு உண்டான முயற்சிகள் எடுத்துட்டு இருக்கோம். ஸோ ஒரு டிஸ்கஷன் நடந்துகிட்டு இருக்கு. அதுவும் முடிஞ்ச பிறகு நம்ம அதாவது ஜிபிக்கு முன்னாடி அதுவும் முடிக்கணும் அப்படின்னு சொல்லி ஒரு டார்கெட் வச்சிருக்கோம். அதையும் முடிச்சிருவோம். ஸோ அந்த மாதிரி ஒரு டீமா செயல்பட முடியும். அதாவது ஸ்டேட்டுங்கிறது தனி பாடி கிடையாது, என்னைக்குமே சொல்றேன். அதாவது எல்லா ஜோனும் ஆக்டிவா வேலை பார்த்தாலும் அது ஸ்டேட், அதாவது ஸ்டேட்டுங்கிறது தனியா கிடையாது. நாங்க வந்து தனியா பண்றதுக்கு ஒண்ணுமே இல்லை, எல்லாருமே சேர்ந்து பண்ணணும். அதே மாதிரி நீங்க வந்து கன்னியாகுமரி ஜோன்ல இருந்து செக்ரட்டரி வந்திருக்காங்க. ஸோ இதே மாதிரி சிஎம்ஏ வந்து கன்னியாகுமரியிலே நடத்தணும் அப்படிங்கிற ஒரு ரிக்வஸ்ட் வச்சுக்கிறேன். எல்லா ஜோன்லயுமே இந்த மாதிரி கண்டினியூஸா நடக்கணும், அப்பதான் நல்லா இருக்கும். ஸோ இன்னைக்கு ஸ்பீக்கர்ஸ் பத்தி கண்டிப்பா நான் பேசணும். ஒருத்தவங்க வந்து இசிஜி வந்து பிரிச்சு மேய்ச்சிட்டாங்க, அடுத்தது வந்தவர் வந்து பஞ்சகர்மா பிரிச்சு மேய்ச்சிட்டாரு. அதுலயும் வந்து ஹைலைட்டே பாத்தீங்கன்னா அந்த கிரீன் டீ வசதிலாம் சொன்னார் பாத்தீங்களா, அதெல்லாம் வந்து ரொம்ப ஹைலைட்டான விஷயம். அதை யாரும் யோசிச்சு பார்க்க மாட்டோம். ஸோ அந்த மாதிரி வந்து குரு சிஷ்ய பரம்பரை நம்ம கேள்விப்பட்டிருக்கோம். அதே மாதிரி சிஷ்ய குரு பரம்பரைக்கு நமக்கு வந்து முக்கியமா தேவைன்னு நினைக்கிறேன். ஏன்னா நிறைய விஷயங்கள் வந்து நம்மளும் அவங்ககிட்ட இருந்து கத்துக்கணும். ஏன்னா நிறைய ஏஐ லெவல்ல போயிட்டு இருக்காங்க. ஸோ அவங்களோட டெக்னாலஜி ஐடியாஸ் அது எல்லாமே எல்லாருமே அடாப்ட் பண்ணாங்க. இன்னும் கூட நம்ம சக்சஸ் ஆகலாம் அப்படிங்கிறது என்னோட கருத்து. மோஸ்ட்லி எல்லாமே அப்டேட்ஸ் எல்லாமே அப்டேட் பண்ணியிருக்கேன். ஸோ இதுல வந்து அந்த கோயம்புத்தூர் ப்ரோக்ராமுக்கு உங்களுக்கு சார்பா வந்து ஏதாவது ஸ்பான்சர்ஸ் ஏதாவது ஏற்பாடு பண்ணி கொடுக்க முடிஞ்சதாலும் பண்ணி கொடுங்க. ஸோ 2 days வந்து அந்த ரேஸ் கோர்ஸ்ல தான் பிளான் பண்றாங்க. ஸோ பப்ளிக் உள்ள வரணும் அப்படிங்கிறதுக்கு வேண்டி ஒர்க் அவுட் பண்ணிட்டு இருக்கோம். ஸோ அதே மாதிரி அடுத்தடுத்த ஒவ்வொரு ஜோன்லயும் வந்து மெகா இவெண்ட் பண்ண போறோம். இன்னொரு சின்ன ரிக்வஸ்ட், நீங்க சிஎம்இ பண்றதுலயே வந்து அத்தியன சீரீஸ்ன்றது ஒன்று ஆட் பண்ணிக்கோங்க. எல்லா எஜுகேஷனல் ப்ரோக்ராமே நம்ம வந்து அத்தியனம் அப்படிங்கிற பேர்ல கொண்டு போறோம். அதோட மெகா இவெண்ட் தான் வந்து நம்ம கான்ஃபரன்ஸ் பண்றோம், பிசிக்கல் ப்ரோக்ராம் as well as ஆன்லைன் ப்ரோக்ராம் பண்றோம். ஸோ அதையும் வந்து நீங்க ஆட் பண்ணீங்கன்னா அதே ஒரு பிராண்ட் அப்படியே நமக்கு கண்டினியூஸா போகும்னு நினைக்கிறேன். மதுரை ஜோன் அதை ஃபாலோ பண்ணுங்க. வாழ்த்துக்கள். இது மாதிரி நிறைய ப்ரோக்ராம் பண்ணுங்க, எல்லா ப்ரோக்ராமும் கூப்பிடுங்க, இதெல்லாம் நாங்க வந்துடுறோம். வாழ்த்துக்கள். நிறைய முயற்சி வச்சுக்கோங்க. தேங்க்யூ.
எல்லாரும் வந்து ஒரு இண்டிவிஜுவலா வந்து கால் பண்ணி வரலன்னா அடுத்த வீட்டுக்கு வந்து கூப்பிட்டு வர அளவுக்கு
அடுத்து நம்ம ஸ்டேட் செக்ரட்டரி அவர்கள்.
அனைவருக்கும் வணக்கம். மதுரை அப்படின்னு பார்க்கும்போது நம்ம வந்து நிறைய தமிழ் அப்படின்லாம் நம்ம நிறைய அங்க வளர்த்து வளர்த்தோம் இருக்கு. பட் இன்னைக்கு நான் பார்க்கும்போது ஆயுர்வேதத்தை வளர்த்தது மதுரை தான் அப்படிங்கிற மாதிரி தான் ஃபீலிங் இருக்கு. இந்த மாதிரி ஒரு சின்ன ஒரு சிஎம்இ ஒரு ஜோன் லெவல்ல நம்ம நிறைய இடத்துல பார்த்துருக்கோம். நம்ம வந்து ஒரு ஸ்டேட் லெவல் மீட்டிங் பண்ணும் போதே நிறைய இடத்துல கோரம் இல்லாம ஒரு 10 பேரை வச்சு மீட்டிங் நடத்த காலம் எல்லாம் போயிட்டு ஜோனல் ஈவெண்ட்டுக்கு மேக்சிமம் இருக்கிற எல்லா ஒரு 90% மெம்பர்ஸ் அட்டெண்ட் பண்ணி ஒரு ப்ரோக்ராம் நடக்கிறது வந்து ரொம்ப சந்தோஷமா இருக்கு. இதுக்கு வந்து சொல்லிட்டீங்கன்னா இந்த சிஎம்ஏ ப்ரோக்ராம் ஃபேமிலியோட வந்துருவோம். ஆமா, அதுக்கு பிரசிடென்ட் அதே ரெடி பண்ணிருக்காங்க. நல்லா இருக்கும். அதே சாப்பாடோட இதுக்கு எல்லாம் வந்து ஒரு முழு முயற்சியோட ஈடுபடக்கூடிய மதுரையோட ஒரு பிரசிடென்ட், செக்ரட்டரி, அதர் எக்ஸிகியூட்டிவ் கமிட்டி சேர், அந்த ஸ்டாஃப் எல்லாத்துக்குமே இது சொல்லிக்கணும். அதுக்கப்புறம் வந்துட்டு இப்போ நான் வந்து பிரேமண்ணாவை பொறுத்த வரைக்கும் அவங்க அப்பா கலந்து பார்த்துட்டு இருக்கேன். அவங்க அப்பாவோட பிரேமண்ணா ஒரு 16 அடி முன்னாடி போனாரு. இப்போ அவரோட மகன் வந்து வைஷாக் தன்வந்திரி அதிகமா 32 அடிக்கு மேல தாண்டுவார்னு நினைக்கிறேன். அந்த அளவுக்கு பார்க்கும்போது ரொம்ப சந்தோஷமா இருக்கு ஆயுர்வேத ஃபீல்ட்ல. அதுவும் அண்ணனோட ஃபேமிலியில வரும்போது ரொம்ப சந்தோஷம் இருக்கு. அப்புறம் ஹரிஹரன் சார் பத்தி நிறைய பேசணும். இன்ன வரைக்குமே எங்களுக்கு எல்லாத்துக்கும் இன்ஸ்பிரேஷன் ஆகும். பிரேமண்ணா ஜென்ரேஷன் வந்து எங்க ஜென்ரேஷன்ல இருந்து எங்களுக்கு அடுத்த ஜென்ரேஷன் வரைக்குமே எல்லாத்துக்குமே ஒரு 10 minutes பேசினா கூட நம்ம வந்து ஒரு பெரிய ஆயுர்வேத டாக்டர் நம்ம நம்ப வைக்கிறாரு. அந்த இன்ஸ்பிரேஷனல் டாக்ஸ் வந்து நமக்கு வந்து எப்பயுமே ஒரு 10 days அவர்கிட்ட பேசினா நான் நிறைய கேஸ் பார்ப்பேன். எனக்கு இந்த ஃபீலிங் எனக்கு வருது. அந்த மாதிரி நிறைய பேர் இன்ஸ்பைர் பண்ணிட்டு நிறைய எங்களோட அத்தியாயன சீரிஸ் வந்து நிறைய ஒரு அவர்தான் ஒரு தொடக்கமும் ஆரம்பிச்சு இந்த வரைக்குமே அது வந்து டைம் எஃபோர்ட் எல்லாம் போட்டு பண்ணிட்டு இருக்காரு. ரொம்ப தேங்க்ஸ். ஹரிஹரன் சார் மாதிரி அடுத்து இங்க இருக்கக்கூடியவங்களும் அந்த அத்தியாயன சீரிஸ் ஆன்லைன் யூடியூப் சேனலுக்கு நிறைய நிகழ்ச்சிகள் கொடுக்கணும். எனக்கு எஸ்பெஷலி மகாலட்சுமி டாக்டர் வந்து ஒரு சீரீஸ் கொடுக்கணும் அப்படிங்கறத நான் கேட்டுக்கிறேன். அப்புறம் இங்க மதுரை டாக்டர்ஸ் எல்லாத்துக்குமே ரொம்ப சந்தோஷங்களை கொடுத்துருக்கு. ஸோ நான் பேச வேண்டியதெல்லாம் பிரசிடென்ட் பேசிட்டாரு. நான் வந்து மெயினாக கூப்பிட வேண்டியது வந்து நம்ம கோயம்புத்தூரோட ப்ரோக்ராமுக்கு 8th and 9th August வந்து ஒரு CME 2 days ப்ளஸ் ஒரு GBA பண்ண போறோம். அதுக்கு வந்து நம்ம பிரேமண்ணா தலைமையில மதுரையில இருந்து எல்லாருமே ஒரே டீமா வந்தீங்கன்னா நல்லா இருக்கும். வந்து ஹரிகரன் சார் மட்டும் கொஞ்சம் வர முடியல, ஒரு முக்கியமான ஒரு ஃபேமிலி ஃபங்க்ஷன் இருக்கிறதுனால சென்னையில் அதுக்காக தான் மறுபடியும் ஆயுர்வேதா டே பண்ண போறோம் சார். எல்லாருக்குமே கூப்பிட்டு எல்லாத்துக்குமே நன்றி. எஸ்பெஷலி மதுரை ரொம்ப தேங்க்ஸ். புது சிஎம் யாரும் கூப்பிட்டுருக்கீங்களா? 8:30 புது சீஃப் கெஸ்ட் யாரு? இல்ல சீஃப் கெஸ்ட் ப்ரோக்ராமோட
சென்னையில பிளான் பண்றோம்.
சென்னை
ஆயுர்வேதா டே ஒட்டி அது
லாஸ்ட் ஒரு 1 month முன்னாடி நம்ம வனிதா மேடம் பார்க்கும்போது அவங்களோட ஃபவுண்டேஷன் நல்லா புது கவர்மெண்ட் வந்திருக்கு, நம்ம ஏதோ ஒரு விஷயங்கள் வந்து மினிஸ்ட்ரி லெவல்லையோ சிஎம் லெவல்லையோ கூப்பிடுறோம். நமக்கு வந்து ஆயுர்வேதா டே அப்படிங்கும் போது அவங்க கூப்பிடுறதுக்கு ஒரு சான்ஸ் அவங்களுக்கு. ஸோ அதனால நம்ம வந்து ஒரு ஈவெண்ட் அங்கே பண்ணும்போது மினிஸ்டர் வரதுக்கான வாய்ப்பு நிறைய இருக்கு. ஸோ அங்கே வச்சு ஏதோ 2-3 அறிவிப்புகள் ஆயுர்வேதம் வாங்கணும் அப்படிங்கிறதுக்காக ப்ரோக்ராம் பண்ணுறோம். ஒரு ½ day ப்ரோக்ராம் ஜஸ்ட் ஒரு அஃபிஷியலாக பண்ணிட்டு ஏதோ ஒரு பாசிட்டிவிட்டி அதில் நம்ம கிடைக்கும்னு எதிர்பார்க்கணும். அதுக்கும் மதுரை சோனோட ஃபுல் பார்ட்டிசிபேஷன் வேணும்.
இதே மாதிரி அங்கே போட்டு
அடுத்தது வந்து ஆகஸ்ட் மாசம் 3rd வீக்ல வைக்கலாம். நெக்ஸ்ட் CME ப்ரோக்ராம் வில்லிங்கா இருக்கிறவங்க கொஞ்சம் நேம் சொல்லணும். ஆனா ஃபர்ஸ்ட் தடவை நம்ம ஃபர்ஸ்ட் CME முடிச்ச உடனே டாக்டர் சொன்னாங்க டாக்டர் நெக்ஸ்ட் கிளாஸ் நான் எடுக்கிறேன். அது ரொம்ப சந்தோஷமா இருந்தது. விஷாக் ஈகரா இருந்தாரு. அடுத்து கொஞ்சம் நீங்க நேம் சொன்னீங்கன்னா டாக்டர் சேக்பரித் என்னப்பா ஆன்காலஜிஸ்ட் அவர். ஆமா என்னப்பா வீரபத்ர சிங். டாக்டர் சேக்பரித் அண்ட் வீரபத்ர சிங். டாக்டர் இந்திரவர்மன். சரிப்பா டாக்டர் இந்திரவர்மன். வித்ரதியா அற்புதம் அற்புதம் அண்ட் ஆன்காலஜிஸ்ட். ஓகே டாக்டர் சேக்பரித். என்ன டைட்டில் என்னன்றத நாங்க வந்து மதுரை ஜோனுடைய இதுல போட்டோம். ஓகே வாட்ஸ்அப்ல. தேங்க்யூ. ஓட் ஆஃப் தேங்க்ஸ் டாக்டர் சார். அதாவது நம்ம இன்னும் வந்து மதுரை ஜோனுக்கு ஒரு பொறுப்பை கொடுக்கலாம்னு யோசிச்சிருக்கோம். அதாவது பிளேஸ்மெண்ட் செல் இல்ல பிளேஸ்மெண்ட் செல். அதாவது நம்ம போன இதுல கன்னியாகுமரி கோயம்புத்தூர்ல நடந்த இதுல எலெக்ஷன் ப்ரொசீடிங்ஸ் தான் வந்து நிறைய யங்ஸ்டர்ஸ் வந்திருந்தாங்க. அவங்களோட குறிக்கோள் வந்து பெரிய சிரமமா இருக்கு, யார் அப்ரோச் பண்றது, இல்ல நம்பகமான ஹாஸ்பிட்டலா அப்படின்னு சொல்லிட்டு நிறைய கேள்விகள் கேட்டிருந்தாங்க. ஸோ அதுக்குதான் வந்து நம்ம ஏற்கனவே நம்ம பேசியிருக்கோம். பிரசிடென்ட் சார்ட்டையும் அதே மாதிரி செக்ரட்டரி சார்ட்டையும் பேசியிருக்கோம். நம்ம ஸ்டேட் செக்ரட்டரி வந்து டிஸ்கஸ் பண்ணியிருந்தாங்க. அந்த பிளேஸ்மெண்ட் செல் வந்து மதுரைக்கு வந்து ஒரு பொறுப்பை கொடுக்கலாம் அப்படின்னு இருக்கோம். ஏன் அப்படின்னாக்க மதுரை வந்து நம்ம சென்ட்ரல்ல இருக்கிறதுனால நமக்கு எல்லா இடத்துக்கும் நம்ம கொஞ்சம் கவர் பண்றதுக்கு ஈஸியா இருக்கும். ஸோ அது எப்படி பண்ணலாம் அப்படிங்கறது ஸ்டெப் பை ஸ்டெப் எல்லாத்தோட கைடன்ஸும் வாங்கிட்டு அதை நம்ம அடுத்து நம்ம முன்னாடி கொண்டு போகலாம் அப்படிங்கிறது பிளேஸ்மெண்ட்ஸ் அந்த வேலை வாய்ப்பு வந்து கேட்கறவங்களுக்கும் நம்ம வந்து அப்ரோச் பண்றாங்க. அதே மாதிரி வந்து எந்தெந்த ஹாஸ்பிட்டல் வேகன்சி இருக்குன்னு நம்மகிட்ட அப்ரோச் பண்ணாங்க. நம்ம எலிஜிபிள் டாக்டர்ஸ் ஃபர்ஸ்ட் ப்ரிஃபரன்ஸ் நம்மளோட மெம்பர்ஸ். அது எப்பயுமே நம்ம ஒரு குறிக்கோளை வச்சுக்குவோம். நம்மளோட மெம்பர்ஸ் யார் வந்து நியர்பை இருக்காங்க, யார் எஃபிஷியன்டா இருப்பாங்கன்னு சொல்லி நம்ம இங்க இருந்து சஜஸ்ட் பண்ற மாதிரி ஒரு ஐடியா இருக்கு. அதே
8th 9th அன்னைக்கு வந்து நாங்க ஒரு ஸ்டால் மாதிரி போட்டு டாக்டர்ஸ் இன்டர்வியூ
பண்ணிக்கலாம். கண்டிப்பா பண்ணிக்கலாம்.
ஒரு மத்த கம்பெனி பெரிய கம்பெனில எடுக்கறாங்கல்ல,
கண்டிப்பா பண்ணிக்கலாம். அதே மாதிரி ஃபுல் டேட்டாஸ் நீங்க கலெக்ட் பண்ணிக்கிறதுக்கு வாய்ப்பு இருக்கு. அது இதுலயும் பண்ணிடலாம்.
நிறைய ஹாஸ்பிடல்ஸ் எவ்வளவு ஹாஸ்பிடல் வந்துருச்சு.
ஆமா
அவங்களுக்கு நீட் இருக்கனால நீட் இருக்கவங்க ஹாஸ்பிடல்ஸ் வந்து அங்க ஒரு சின்ன கேம்ப் மாதிரி போட்டு ஆன் இன்டர்வியூ பண்ணி கூட they can
பண்ணிக்கலாம். அதே மாதிரி தெரபிஸ்டிங் கூட அதுல ஆட் பண்ணிக்கலாம் அப்படின்னு வந்து சஜஷன் வந்தது. ஏன்னா ஹை டிமாண்ட் இருக்கு. ஸோ அதனால அவங்களையும் வந்து தெரபிஸ்ட் முடிச்சவங்களோட லிஸ்ட் வாங்கி வச்சுக்கிட்டு இங்க வேகன்சி இருக்கு நம்மள அப்ரோச் பண்ணாங்க. நம்மள வந்து ரெண்டு சைட்லயுமே நமக்கு வந்து கொஞ்சம் ஈக்குவல் பண்றதுக்கு பெட்டரா இருக்கும் அப்படிங்கிறதுனால ஸோ இந்த பொறுப்பை வந்து நம்மளுடைய பிரசிடென்ட் தலைமையில வந்து செக்ரட்டரியும் சேர்ந்து செய்து நீங்க சப் கமிட்டிஸ் போடுங்க. அதே மாதிரி ஒவ்வொரு ஜோன்ல இருந்தும்
ஒரு 1-2 பேரை நீங்க எடுத்துக்கிட்டீங்கன்னா எல்லா சோன்ல இருக்கக்கூடிய டீடைல்ஸ் எல்லாமே நமக்கு வந்து டைப் பண்ண முடியும். ஸோ அதை நம்ம எப்படிங்கிறது நம்ம டிஸ்கஸ் பண்ணிட்டு நம்ம பண்ணுவோம்.
சார், அதாவது எங்களுக்கு என்ன ஒரு டிஃபிகல்டிஸ்னா, இல்ல இதை நாங்க கண்டிப்பா செய்யறோம். கொஞ்சம் எங்களுக்கு கால அவகாசம் கொடுங்க. ஃபர்ஸ்ட் நாங்க சிஎம்இ ப்ரோக்ராம்க்கு ஆள் சேர்க்கிறது இல்ல சிஎம்இ ப்ரோக்ராம் அதை விட அதுக்கு வந்து ஃபைனான்ஸ் வந்து ரொம்ப தேவைப்படுது. இதை வந்து எப்படி கலெக்ட் பண்றது, இப்ப ஃபைனான்ஸ் எப்படி ஃபர்ஸ்ட் சிஎம்இ ப்ரோக்ராம் ஆளை கொண்டு வரது பெரிய விஷயம், பணம் கலெக்ட் பண்றது பெரிய விஷயம். அது எங்களுக்கு கொஞ்சம் இதா இருக்கு. கொஞ்சம் நாங்க ஸ்டேட் பண்ணிக்கிறோம். ஸ்டேட் பண்ணிட்டு நீங்க சொன்ன விஷயத்தை ரொம்ப சிறப்பா செஞ்சு
So 2 minutes out of thanks so much, sir. Thank you, Hariran sir, for coming to today's event. காலையில நான் 9 மணிக்கு வந்தேன் சார். 9:45 இங்க மெசேஜ் போட்ட மாதிரி ஷார்ப்பா வந்தாங்க. கூடவே வந்து நம்ம கனெக்டிங் ஜோனோட செக்ரட்டரி டாக்டர் கார்த்திகேயன் சார் சேர்ந்தாங்க. So thank you sir, thank you for being on time and gracing is the occasion. குரூப்லாம் பத்தி நீங்க இந்த டைம்ல வந்து ரெஃபர் பண்ணா நமக்கும் நல்லது, அவங்க பேஷண்ட்டுக்கும் நல்லது, முக்கியத்துவத்தை பத்தி நீங்க ஷேர் பண்ணிட்டீங்க. Thank you sir. Next today's speaker Dr. Mahalakshmi. பட்டாசு வெடிச்ச மாதிரி இசிஜி பத்தி நமக்கு வந்து இனிமே ஒரு இசிஜி பார்க்கும்போது அதை பத்தி கிடைக்கக்கூடிய கிளாரிட்டி என்னன்றதுக்கு நமக்கு ஒரு இன்சைட் வந்து மேடம் ஷேர் பண்ணியிருக்காங்க. மேடம் ஃபர்தர் இன்னும் நீங்க ஒன் மோர் கேசஸ் நீங்க பார்க்கும்போது அதை பத்தி இருக்க ஃபர்தர் செஷன்ஸ் நீங்க கொடுக்கணும்னு சொல்லி நான் தாழ்மையா கேட்டுக்கிறேன். நெக்ஸ்ட் வந்து நம்மளுடைய டாக்டர் விஷாக் நன்றி. தைராய்டு பத்தி ஹைப்போதைராய்டு டீடைலா ஒரு எப்படி நம்ம பஞ்சகர்மா படிக்கும் போது கிளாஸ்ல எப்படி நம்ம டீடைலா ஒரு ஸ்டடி A to Z ஸ்டெப் பை ஸ்டெப் போவோம். அதே மாதிரி நீங்க ஒரு செஷன் வந்து கிளாஸ் வந்து ப்ரொவைடர்ஸ் அண்ட் ஆல்சோ அதுக்கான டவுட்ஸ் ரிலேட்டட் வந்து எல்லாத்தையுமே ரொம்ப ஈஸியா புரியுற மாதிரி கிளாரிஃபை பண்ணியிருக்காரு. அதுக்கு ரொம்ப நன்றி. தேங்க்யூ விஷாக். நெக்ஸ்ட் நம்மளோட காம்பரேட்டர் டாக்டர் கருணாவிகா. தேங்க்யூ டாக்டர் அண்ட் டாக்டர் நந்தகிஷோர் ஃபார் ஹெல்பிங் மீ வித் கம்ப்யூட்டர் ரிலேட்டட் ஆக்சஸ் டெக்னிக்கல். And I also like to thank our sponsors, Dr. Apex Laboratories, Mr. Bala sir, Mr. Prakash and Mr. Lingesh for helping in organizing this event. And Gopik, Venkatesh and Shankar sir for helping for this event. And our venue partners from Prem Nivas. Thank you to them. And we have a special guest from the state Nigerian sir and Secretary Dr. Arun sir. ரெண்டு பேருமே வந்து இன்னைக்கு இந்த ஃபங்க்ஷன் வந்திருக்காங்க. The program sir. Lunch ready ஆயிடுச்சு. Kambu Catering has prepared a special lunch for us. எல்லாரும் நம்ம சீக்கிரம் சாப்பிட போலாம். Next week continue national national